Dr. Ravi, good evening.
Hi, Amit. Can you hear me?
Hi, Samishnu. Can you hear me?
Yeah, clear.
Dr. Ravi, good evening.
Good evening, sir.
Am I audible?
Sorry, there was some technical issue, sir. Actually, I don't know. There was a problem with this YouTube streaming. There was one link which we had created, and that was supposed to do the YouTube streaming also, but that link was not working. So we have sent another link to all the participants and the delegates also. And YouTube streaming is now working fine with this link.
Okay. Am I audible?
Yes, sir, I can hear you. Good evening to everyone.
So we can give them some time, I guess, isn't it?
Yes, sir, we can. I think we should wait for 5 minutes. Let Dr. Ishwar Singh and Dr. Pasi also join. I have sent the link to them also.
5-10 minute de dete hain.
Yes, sir. Yes, sir.
अंकल जी अंकल जी कुछ बचा है और शुड आई नहीं कुछ नहीं लोगे no thanks क्या हुआ अंकल जी don't sound happy नहीं ऐसी कोई बात रोनी की पर्सनल बात तुझे ऐसे ओपनली नहीं करनी खैर क्या नॉमिनेशन भर और शुरू कर अपनी राजनीति थैंक्स बट आई वाज वंडरिंग वो कल रोनी की सभा है कुछ करना चाहिए कुछ दिया तेल नहीं बचा इसलिए अगर वो फंसा है क्या इलाज करना है उनको कुछ अच्छे से मालूम ओके कीप योर ब्लेसिंग बाप की मौत को मर्डर बता दिया मैं खिलाऊंगा पता सकुजी से भी ज्यादा चलबाज है महाभारत फिर से अमीरों के पक्ष में जा रहा है सारा प्लान चौपट हो सोचा था वीडियो से उसकी हवा बनाएंगे थोड़ी रेलिंग से उसका सच सामने लेके आएंगे तो हमें कौन सा पता था यार कि वो अवंतिका ही कहानी लेके आएगा इतनी पुरानी बात उसके बारे में बोले ही जा रहे हैं गाड़ी मुझे उखाड़े ही जा रहा है सारे कुछ और बात करो ना या वो बंदे की चैंपियन वाली लड़की मिली थी अच्छी लड़की है भैया सृष्टि नाम है कहने लगी आजकल दौड़ने नहीं आते क्या है मैंने भी तो पुलिस में भर्ती होने का सोचा अभी तो खुश रहे दूसरी लड़की तो भी अपन तो घर से गए बाप से गए 6 लाख से गए वो तुम्हारा अंकल ने भी मना कर दिया ना यार अबे तुमने देखा है लड़की कैसे करता है तुम्हारा अंकल मना नहीं करेंगे तो क्या करें कैसे बताता है कभी वीडियो पे कभी गाड़ी तो कौन खड़ा होगा आपके साथ यार अब तो मुझे भी लगता कल भी गया
बुखार और
टेंट वेंट में हो गए पैसे बर्बाद चलते पैसे
एक्सप्रो दे दूं पहले
समोसे खाना पीना चाय
फोन मैं तो जूम मीटिंग से एग्जिट
बहुत दर्द हो रहा है क्या तो फिर वो कॉलिकेट दे देती ना फिर
वाईफाई लेके फोन नहीं
पूरा नहीं है ना अब
रवि
उमंग तुम खड़े हो जाओ यार उसके पास तो जाओ एक बार
हेलो
ये तरीका है यार
हेलो हेलो
गुड इवनिंग ईश्वर सर. सर आप you are audible sir.
I'm audible. हेलो हाँ रवि हेलो हेलो
Hi, Dr. Amit. How are you?
Hi, Sumit. Good evening. Hi, Dr. Ishwar, sir. Good evening.
गुड इवनिंग सर.
Good evening, Dr. Ishwar. How are you, sir?
बिल्कुल बढ़िया. रवि शुड वी स्टार्ट? रवि हेलो
Ravi was there some time back. वो temporarily disappear हो गए.
हेलो रवि
Hello.
गुड इवनिंग सर. डॉक्टर पासी डॉक्टर किशोर.
Hi,
Yes.
good evening.
Good evening. Good
Pastor, sir.
evening. Good evening.
रवि इज नॉट ऑडिबल.
वो है नहीं यहाँ पे. अभी थे. I spoke to him some time back. Disconnected him.
I think we can start, sir.
In fact, Ravi was waiting for you, but I think वो कहाँ चले गए पता नहीं.
Sir, good evening, everybody. Everybody is muted.
No, I am not muted. Can you hear me, Ishwar?
Yeah, you are audible, sir.
Okay. Hi, Dr. Amit.
Good evening, sir. Good evening. कैसे हैं sir?
I'm good. I'm good. Nice to see you after a long time.
जी sir, likewise.
So we start, sir.
Yes, why not? We are already late a bit. But
good
let
evening.
Amit, before Amit starts, I think we should ensure that there are some people around.
There was some issue with the link. Ravi was telling me, so he's
Huh.
had to send the fresh link to everybody.
He has sent the fresh link. I have connected
Got the
through
fresh link,
the
sir.
fresh link only.
Sir, good evening, sir.
Good
Yes,
evening,
Ravi.
Sir, sorry for the technical problem. Actually, there was a link which was sent to everybody, and then we thought of YouTube streaming also, and the YouTube streaming was with the other link. I mean, so there was some confusion. Now we are actually online, and the meeting is being YouTube stream also.
So should we start, Ravi? Hello.
Sir, sorry for the technical problem. We are now live, and we are having YouTube streaming also right now, and I think we can start. I have sent the fresh link out to all the delegates.
So good evening, everybody. I welcome all of you on behalf of Delhi OI. In continuation of our CME series, we had on mucormycosis, then second was on tumors of paranasal.
Sir, we can't hear you, sir. Dr. Ishwar,
you are not audible, sir.
You are not audible, sir.
Hello, good evening, everybody. I welcome you on behalf of Delhi OI. We have a series of CMEs. First one was on mucormycosis. Second, we had on tumors of nose and paranasal sinuses. And this is third in continuation. Today, we have a very important topic, and that is on cochlear implant. And we have an eminent speaker, Dr. Kishore, Amit Kishore, and then we have a panel conducted by Dr. J.C. Pasi, who is a professor, who was professor and director at Maulana professor at Maulana Azad Medical College. So Dr. Amit Kishore, who is a known neuro-otologist, he had double FRCS. He passed. He did his UG from undergraduation from AFMC Pune, and then he was trained in UK. He's professor of this thing, ENT, at presently working at Indraprastha Apollo Hospital, New Delhi. Sir is a known cochlear implant surgeon. He is working in this field for last 25 years. So with this introduction, I welcome Dr. Amit Kishore for his lecture.
Good evening, everybody. Are my slides visible, sir?
Yeah.
Yeah.
Thank you. So, good evening, everybody. Thank you very much to the Delhi AOI and Professor Ishwar Singh for the introduction and the opportunity. Right, the topic of my talk was pearls. I'm not going to be talking about pearls, unfortunately, ladies, because I don't know much about pearls, but we are going to be talking about pearls in cochlear implant surgery, which is equally important and equally precious. So in the half an hour that we have that's been given to me, I'm going to try and cover whatever I can as important pointers. Now, I know that everybody in the audience has had a fair amount of exposure and experience of various levels in cochlear implant surgery, so this is nothing new, but hopefully we'll be able to highlight some of the important factors that we as surgeons should be knowing. So what is the aim? What is our aim in the whole process of cochlear implant management? We are one member of a much larger team. Each of us has our own responsibilities, and we all have ours too, to be able to contribute to the best possible outcomes. And from the surgical point of view, we want to anticipate and manage potential challenges, the surgical challenges, and also minimize potential surgical complications so that everything else falls in place. So what I thought I'll do is I'll reverse the talk. We'll go the other way around. Let's all think about the potential problems and challenges that we might face, have faced, or have seen, and let's see how we can avoid them. So, for example, we may have seen issues with flap, for example, infection, hematoma, or necrosis of the flaps. We may have seen issues with device migration or extrusion. We may have encountered facial nerve trauma during the surgery, or facial nerve stimulation or paralysis post-operatively. And a very common challenge that a lot of us, and especially the novice surgeon, might face is access to the round window. And during that process, trauma to the external auditory canal, difficulty in exposure and getting the right angle of insertion into the round window, thereby either having difficulty in inserting the cochlear implant or electrode, we may damage the electrode in the process, or we may not be able to preserve the intracochlear structures. And this may also result in incorrect placement and possible extrusion of the electrode. Occasionally, we may be faced with an issue of CSF leak and very infrequently, not often recognized, dizziness. So I think you'll agree that these are all the issues that we as surgeons might have seen and hopefully not faced all of them, but certainly would have seen these in some form. So we'll start one by one. Now, this is something that, of course, is very, very simple to avoid. It happens, unfortunately, but it is very, very easily avoidable. Flap necrosis, device exposure, or device extrusion. So very simply, how do we do that? The first is infection control. That's needless to say, but it's a very, very simple thing. We practice removing hair at the operative site just on the operating table and not before that, would expose the bugs. And of course, using good quality preoperative surgical scrub. Use the prophylactic antimicrobial agent as per the criteria for a clean wound. And one point that I would like to make is that we must adhere to validated methods of sterilizing surgical instruments and adhere to principles of asepsis in cochlear implant surgery. This is not chronic ear surgery, and you have to think of maybe knee replacement or hip replacement surgery, because we are, at the end of the day, inserting an artificial prosthesis into the ear. So just a point of caution because all the senior surgeons on the panel have been involved in mentoring other centers, and this is something that is often seen. So when you are marking the incisions for your cochlear implant, be it for a BTE processor or be it for an over-the-ear processor, ensure that we have adequate distance between the incision line and the point of the receiver stimulator, about a centimeter, centimeter and a half. Get the angle right if you're looking at a BTE, an OTE processor, because remember, the processor microphone has to be sitting in a near physiological position. So when you are making that skin incision, if it's too close to the skin incision, you have a greater likelihood of exposure. I've always supported and suggested a double flap technique. So you should have a staggered incision of the skin and your musculoperiosteal incision being different. You may decide, as in this case, to use a posteriorly based flap. You may decide to use a superiorly based flap or a large palva anterior based flap, whatever is your comfort to get adequate exposure. But the idea is a two flap technique. I never use the monopolar. You can very easily manage with good infiltration and minimum bipolar use, because unipolar, especially in the small children, you will have tissue loss and vascular damage. Once we've done that, of course, you want to get a good bed for device stability and fixation. You may choose to go the traditional way and fix the device using sutures in the device bed. We still do that, although a lot of surgeons may decide just to go ahead and make a pocket and place the device in the pocket in one of the newer devices where you have a profile type device. It's important in that situation, in whichever situation, to ensure that the anterior edge and your inferior edge of your well is well perpendicular and has a good sharp edge to it, because that's where the device is likely to slip anteriorly or anterior-inferiorly. So if you've got that well made with a good edge here, then you're less likely to have that device slipping through, and it will sit snugly. Having said that, I still tend to tie. I think in our situation where device is a premium, it's not covered by insurance, I think spending a few minutes more and putting a suture down to fix it always helps us sleep better at night. So we've made the bed and we've done the cortical mastectomy. Now I quickly hasten to mention that the standard technique that I'm talking about is the mastectomy posterior tympanotomy technique, because that's what's standard across. Of course, people have their choice to use other techniques if they wish. Now, the second important thing is, once we've made the cortical mastectomy, we are now looking at access to the round window. Now, there are a few things here. The first is, yes, we have to take care of the facial nerve. This is not something that we want post-surgery. So how do we do that? First of all, it comes down to our basic science. Now, basic science of understanding the anatomy of where the facial nerve might be in the chorda tympani when we are creating that facial recess approach, and understanding and the radiology. We should all learn to understand our radiology. We have a radiologist on the panel. We should also be able to read the scans ourselves so that we can understand, and we'll talk about that in a few minutes, we can understand the nuances and therefore plan our approach and preempt any issues. If you have access to a nerve monitor, then by all means, please use that. It does not replace good surgical anatomy or surgical technique, but it does help. And certainly medico-legally, if you had it in your OR and you did not use it, then you might be on a sticky wicket if there was an issue. And I think the more you use it, your nursing and technical team will get more accustomed to how the nerve monitor works. So for example, we look at this quick video of most of the videos I will show you are going to be right here for the sake of ease. Everybody knows this, but once again, just to reiterate the important points of adequate copious irrigation, using a diamond burr, and creating the facial bottom. Now, there are two ways when people talk about how to avoid damage to the facial nerve. The first is, okay, let's look at the short process of the incus. Let's go on a vertical along that. And from our knowledge of temporal bone anatomy, we know where it's likely to be. The second is that you identify it. So my take is that the easiest way to avoid injury to a structure is to know exactly where it is. So once you have drilled on where you think the facial nerve is. You've seen the bone or the sheath of the facial nerve. You exactly know where it is. You've thinned out the canal. You know where the chorda tympani is. And then you can bravely go through the space without gingerly going across and inadvertently hitting the facial nerve till you've seen the round window niche. So you could do that. Some people prefer to go down the long route and expose the nerve along the digastric ridge and then come up. Whatever you like to do, if you identify the facial nerve and bring the bone down to it, then that, I think, is, in my opinion, the safest way to avoid damage to the facial nerve. Now, in the process of access, sometimes if we are not very sure and we want to go very anterior because we are scared of the facial nerve, then this is what happens. This was the initial steps of surgery done by one of my fellows. And so, of course, this is where he went. And you go a little anterior in the process of thinning the posterior canal, because that's what you want to do to get good access. And you might inadvertently go into the posterior canal, into the external auditory canal, or damage the annulus or the tympanic membrane. So watch out that you don't do that. If it does happen, then please do correct it at the same time. Make sure that you use some cartilage or bone dust and fascia to reinforce it, because you do not want an acquired epithelial retraction or a cholesteatoma pearl or any infection going in through that. So yes, avoid it if you can, but if it happens, the sky doesn't fall, do correct it, recognize it, and correct it at the same time. So having done that, we are now looking at the round window, we're looking at access, and we have to put the electrodes in. Now, in that process, the electrode finds its way in a different place. This is what we want to avoid. Now, these are some of the X-rays of patients I've seen done elsewhere. You find the electrode in the hypotympanum, crumpled up here. You find it down the eustachian tube. You might find it in the carotid canal. Of course, these are things that you and I certainly want to avoid at all costs. So how do we do that? Again, it comes down to knowing our anatomy and understanding the radiology. So practicing on temporal bones, looking at the imaging, the test during surgery is one of the key things. So always reiterating that let's look at our anatomy, and we should not have this situation in the OR that we're looking for something that at that moment in time.
अब आएगा आपने ऑडियो ही नहीं ज्वाइन करी
In that situation, there are some viewers whose mics are not on mute, but I hope I can talk above their volume and get you to hear. So one of the things that I would bring to notice for some of our junior colleagues is this nice paper by colleagues, Ved and Manoj from Pune and Calicut. And if you need a copy, then let me know. It's a simple image-based grading system based on CT scan. It's good for the novice surgeon. I think even if you don't use it as a scoring system, I think it's a good exercise for our junior surgeons to go through, because it tells you all the points that you should be looking for when you're doing a CT scan and analyzing. For example, there are various things that are given points on this imaging system. And some of the highlighted ones are, for example, the size of the facial recess measurement. You look at the position of the vertical descending facial nerve vis-a-vis the round window, whether it's deep or whether it's more lateral, and might make it difficult for access to the round window niche. There are some lines that you can draw looking at the posterior canal wall vis-a-vis the sigmoid sinus to tell you the angulation of the cochlea vis-a-vis your angulation of the posterior tympanotomy. And again, the same thing along the axis of the cochlear duct versus the external auditory canal, again from round window access. So these are some little things that a lot of us have inherently learned, but this is brings some objectivity to it. And I think it's a good exercise for our surgeons to go through and understand. And again, this was initially described by Bill Gibson, the angulation of the internal auditory canal. And of course, if it's obtuse or versus the more obtuse is it, the better it is. So in fact, we looked at this. So I got one of my junior colleagues to have a look at it about 2 years ago. And we looked at about over 100 kids who went through cochlear implant, and we looked at the imaging, and then the surgeon independently looked at at the findings, and we found that lots of these things did help. For example, the pneumatization of the mastoid in terms of the correlation of difficulty during the mastoidectomy, the size of the facial recess and overhanging facial nerve with regard to facial recess axis, the axis of the basal turn of the cochlea with regard to the round window axis, and basal cochlear axis line with regard to the ease of insertion. So lots of things did come in handy. And then, I should say, sir, on this one, the angle is a bit off, so you might have difficulty, getting a view of the round window, for example. It may not matter to a lot of you senior experienced surgeons, but I think it's good for the junior surgeons to know. Now, sometimes you'll have a difficult situation like this. You'll have a situation wherein the mastoid is very, very small. This is a jugular sigmoid just coming along the posterior canal wall. There is just no space to create a posterior tympanotomy. In those times, you have to have another option up your sleeve, and that's where it's a good idea for us to know about the suprameatal approach. It's not my primary approach, but I've probably had to do this a handful of times, maybe in 5 or 7 patients out of the 1700 that we've done. And in which case, we do create a small antrotomy, we do remove the incus, and then you can feed the electrode through that down into the round window, and you can gently feed that electrode into the cochlea. And as you can see, the sigmoid sinus here is just up against the external canal wall. Of course, you can fracture the external canal wall and bring it forward. You can compress the sigmoid sinus, but it's a good idea for a surgeon to have a variety of approaches in his or her armamentarium and see what's best. And this is something that you can preempt during your reading of the CT scan. So, so that's one thing just to bring to your notice, that you can use other things. Of course, here you would be better off using a straight array. It might be quite tricky doing this with some form of a perimodialar array. So, right, now you may also land up in your experience as you're growing your cochlear implant program with a variety of cochlear anomalies. Yes, about 20-25% of your patients are likely to have one of these: a large vestibular aqueduct, or an IP2, maybe an IP3, common cavity, and ossified cochlea for whatever reason. So we have to develop the experience for that, and there will be some tricky situations in these patients which you have to be prepared to address at the time of the surgery. So one of the tips that I can share with you is intraoperative fluoroscopic guided insertion. Now, this helps in situations like a common cavity or an IP3, where you have the possibility of the electrode. You cannot use a perimodular array, and you have the possibility of the electrode going down the internal auditory canal. So if you are using intraoperative fluoroscopy, where you're inserting and your assistant is telling you on the fluoroscopy at various shots that the electrode is taking a nice turn, for example, in this child with an IP3 anomaly, then you can be reassured that your electrode is in the right place. So it's well described, and a little tip that you can do using an intraoperative C-arm fluoroscopy. So for us surgeons to be able to perform our surgery uneventfully and efficiently in the OR, we have talked about some basic science things. We've talked about the importance of good imaging and understanding and reading the images yourself. Of course, knowledge of audiology is also important when it comes to patient communication. There's another pearl that I will share with you, and that is your colleagues. So our colleagues are always out there to help us, and therefore we should not hesitate to pick up the phone either before the surgery, preferably, or even on the table, and say, look, hey, I'm running into this issue. What should I do? We've all helped each other out, and I think that's always a very good thing, rather than have a disaster post-operative, and we realize that a bit later because the patient is going to suffer. Now, we talked about access, we talked about flap, round window visibility, and we're going to talk about cochlear implant electrode insertion. Now, we have to remember that our aim in today's day and age is to preserve residual hearing and to preserve intracochlear structures as much as we can. It's very, very clear in the science out there that that's what we must do. Now, to be able to do that, Of course, we need to have electrodes that are of appropriate dimension and mechanics to avoid a lot of intracochlear trauma. There may be a role of medication. We won't be talking about that, but there is also our responsibility to ensure that our surgical technique is the best possible to be able to do that. And that is why we're going to very, very quickly go through the two options of electrode insertion. So one option, of course, is the round window insertion. There is a move now for quite some time for a preference towards round window insertion or an extended round window insertion. I remember when I started doing cochlear implants in the mid-90s, at that time it was a standard cochleostomy approach, and the cochleostomies were in fact placed anterior to the round window. And I'm sure in those patients, a lot of the time we must be getting into the scala vestibuli. And then the cochleostomy moved down to an anterior inferior direction. With better arrays, slimmer, more flexible arrays, we are moving towards round window insertion. So what are the tips I can share with you? You want to have good round window membrane exposure. So you want to very carefully drill away the ledge so that you can see the round window completely and get that completely in your view. If possible. That can be difficult sometimes in some children, especially if they're very young or the orientation of the cochlea is not favorable, but this would be the best case scenario. Very careful incision of the round window membrane using a pick or a hypodermic needle to gently incise the round window membrane so that you can get access into the scala tympani. Once you've done that, you may elect to use steroid, local steroid like dexamethasone, instilled into the basal tone or locally, and through that incision, you then want to insert your electrode. Now, here I would again share with you a point that you need to keep in mind is your direction of electrode insertion. What should be the axis of your electrode, because you want that to be as parallel to the basal turn of cochlea. So you have to remember that the basal turn of cochlea is moving away from you. It is going in the direction of the patient's nose, so to speak. So you've got to insert the electrode somewhat going from a superior to inferior direction, and you very gently, slowly, one bit at a time, a millimeter at a time, you're inserting that electrode. Because if you are going to insert the electrode from inferior to superior, you're very likely going to hit the osseospiral lamina. And if it's a firm electrode, then you're going to fracture that, and you're going to probably fracture the basilar membrane. So that's the round window insertion for a situation where you can see the complete round window and you have an electrode that is suitable for a round window insertion. Now, sometimes you may not see the round window in entirely, or the electrode that you use may not be suitable for that. So in that case, you would want to extend the round window, and your cochleostomy is an extended round window cochleostomy. That's what I would prefer. Unless really I've got to make a separate cochleostomy and inferior to the round window membrane. So that's the round window. You remove the ledge. So your cochleostomy is in relation to the round window membrane. So you first need to expose the round window membrane if you can, and then you would drill away the bone which is in the inferior or anterior inferior, more inferior to that round window membrane very, very carefully, using slow speed, lots of irrigation, preferably even with steroid, till you can widen that opening into the basal turn of the cochlea to allow that particular electrode to be inserted as atraumatically as possible. So we'll just jump that. And so that's a contour advance electrode going in. This type of electrode is not designed to go through the round window. So in that case, you have to either make a separate cochleostomy or an extended cochleostomy. So that's the tip on exposure of the entry point for the electrode and how to ensure that you get the appropriate angle of insertion, so that you don't damage the electrode, you don't crumple it when it's going in, and you do not damage the intracochlear structures. Last few points, sometimes you are going to we talked about one of the issues that you might have is a CSF leak. So If you're dealing with an IP3 or an IP1 or a common cavity, you're going to get a CSF leak. Now, this is not what you see in an enlarged vestibular atrophy where you just get pulsating perilymph. This is good going CSF leak. Again, you should be able to preempt that by looking at your imaging beforehand and looking for the continuity of the internal auditory matrix with the cochlea. So be prepared for that. Allow the CSF to drain out for some time, maybe elevate the head. But at some stage, you're going to have to go in there. So you're going to wear your swimming goggles and you're going to take your snorkels and you're going to dive in with the electrode and you're going to put that into the cochleostomy. Sometimes actually it helps to make a slightly larger cochleostomy because then you have to also pack the cochleostomy with strips of periosteum or muscle. And it helps to have a slightly larger cochleostomy to be able to do that more effectively. You may decide to use tissue glue as we did in this first patient, but after that, I didn't use tissue glue. You may decide to use a lumbar drain. I haven't had to do that, but that's an option that you have. And of course, keep the head end elevated post-op, and you may decide to use acetazolamide. There is an electrode designed by Medel called the Form electrode, which is designed for this, whereas this conical plug goes into the round window and blocks that. So a few tips on how to deal with a CSF leak should you find one. Probably finally is you're going to also get some intracochlear ossification in some of your patients with otosclerosis or meningitis. Again, this is always a challenging one. I find this very challenging because no matter how hard or how well you read your imaging, you can always have surprises on the operating table. So you have to be prepared for that. You've got to be prepared with a variety of different arrays. You need to have a depth gauge or a dummy electrode in. You have to drill out that ossified tissue, and you could see that white ossified bone looks different from the otic capsule bone. You've got to sometimes imagine which direction the cochlear lumen is going to go and keep picking at it and drilling it till you hit oil and you see the fluid coming out. And that's when, I heave a sigh of relief and say, thank God. Then insert the appropriate electrode. Sometimes that's not possible if there's a lot of basal turn ossification, and we have to be prepared for an apical cochleostomy just anterior to the footplate of the stapes. Double arrays are not used very often because you can do that, but they're a challenge, and they're even a bigger challenge to map. So ossification is a challenge of a different type, which we have to be prepared. And certainly this is one where I would like to have a colleague or a friend stand by me because you never know what to expect. So always another little tip, I think it's a good idea that we always check the position and the integrity of our electrode at the end of the surgery. Now, we are all doing intraoperative testing, neural response testing, ECAP measurements, but I think it's a good idea also, if you're not sure, to do an intraoperative fluoroscopy C-arm image, because you can always correct something on the operating table. Again, mandate to get an X-ray, proper quality X-ray post-surgery that which you hand over to the patient, because that also gives you a well-documented evidence of the position. And if something changes in future, then you've got something to go by in case of the electrode having migrated, or there might be an issue with where the audiologist wants to know the positioning of the electrode from the mapping point of view. So that's another thing that I think we should keep in mind. So finally, we talked about the aim of surgery and the aim of the surgeon, and we mentioned the fact that, yes, we have an important role to play. We are a member of a much bigger team. We have to do our bit to the best possible to ensure that we contribute to the best possible outcomes, and we do it effectively, efficiently, and minimize the complications by preempting what we have by knowledge, good knowledge of anatomy and imaging, because CI surgery is not only about surgery. We need to understand our anatomy. We need to be able to read the imaging. We should have some basic knowledge on audiology and habilitation, so that when the team is discussing, we're all on the same page. We have to ensure that our techniques are precise and up to speed, and we keep improving on our techniques. Attention to detail. So what I've shared with you in the last half an hour is things that you know already, but just a few finer points where you want to place attention to details so that you have the minimum chance of error. we should not hesitate to ask for help from our colleagues. We've got a lot of experience out there, and it's only for the benefit of the patient. And of course, we should always be open to keep practicing and to learn. So with that, I thank you for your attention. And of course, I have to thank our team that supports us for the last decade, without which we wouldn't be able to help all our patients. So thank you very much again to the Delhi AOI for this opportunity.
Dr. Ishwar Singh, sir, please unmute yourself.
Thank you, sir. Thank you, Dr. Amit Kishore, for such a wonderful lecture. You have shown all and this thing, given tips to the new beginners like us, and we had such a lucid and wonderful lecture. Thank you so much, sir. You be the part of one of, as a panelist, and I think there may be some questions, and we'll take at the end of the session. And now
Sir, sir, if you permit, can I ask one question, sir?
Yeah, even I would like to ask one question, Ravi. I would like to ask a question.
We have to
After
ask
you.
Dr. Pasi. Chalo, sir, should we?
Okay. I think we can stop. We can ask.
Dr. Amit is not supposed to go away. He should be
I'm
here
very
till
much
the
here,
end,
sir.
and
going
we
to-
are going to be after his life at the end.
I'm going to stay here because there's the luminaries on the panel, and I'm going to stay because I'm sure I have something to learn from everybody. So I'm very much here.
So with this, you be on the panel, sir, and we'll have question session at the end. Now I invite Dr. Pasi, who has recently retired from MEMC as director professor, and sir is a known face of the otologist in MEMC, plus at the national level. Sir is doing cochlear implant for last 15-20 years. And with this small introduction, I invite Dr. Pasi to conduct the panel.
Thank you, Dr. Ishwar, Dr. Ravi, and all the executive members of the Delhi AOI for giving me this opportunity to moderate a session on cochlear implantation, and with the galaxy of stars as my panelists. You can yourself see I have Dr. N.N. Mathur. Dr. Mathur is there. Yeah, I can see him. Welcome, Dr. Mathur. Dr. Mathur has also, he has not retired, but he has just been relieved of his administrative responsibilities as director of Lady Hardinge Medical College. And I think he is back to the department now, and he is in a better position to contribute for ENT services now for next 3 years in Lady Hardinge Medical College. Dr. Rakesh Kumar.
Yes, sir.
Is the professor of ENT at AIMS. Dr. Rakesh Kumar, I do not want to accept him with all the gray hair. I have seen him in all black hair since the time he joined AIMS. But anyway, I think he requested me to join a bit late. Dr. Shalabh Sharma is there. Dr. Shalabh. Dr. Shalabh is a senior consultant at Gangaram Hospital and doing lots and lots of Dr. Shalabh, I can't see you yet. Are you there? Dr. Shalabh, yes, I can see him now. Yes, Shalabh, welcome. Shalabh, unmute yourself, please.
I've unmuted myself.
Okay, yeah. Now we can hear you. I have Dr. Someshwar Singh with me. He is another stalwart in the field of cochlear implant surgery in particular, and doing lots of academic work. We are going to hear some of his today. Dr. Jyoti Kumar is a young professor of radio diagnosis in my institution, Maulana Azad Medical College, and very much interested in our temporal bone, which is said to be a complex bone, and she is trying to make it easy for reading for our cochlear implant purposes. Dr. Nivita Narayan, she is the most famous audiology and habilitation specialist, post and pre-cochlear implant surgery. Dr. Nivita, are you there? You now. Welcome, Nivita. I'm seeing you after a long time.
Hello, sir.
Hello, Dr. Ravi Meher. We all know him. I don't need to introduce him. About the cochlear implant panel, I think Dr. Amit has done a lot of things which I was supposed to do, and he has made my task quite easy. Now I'm feeling very easy, and I will just do very basic things with all of you. I have designed the panel discussion in a slightly unconventional way today, and in that I'm actually giving some time to our worthy panelists for their small presentation. To begin with, I will ask Dr. Jyoti Kumar to tell us, and all, especially our junior ENT group of the city and the NCR, and of course, wherever people are watching this program, about how to read a normal temporal bone and also the various anomalies which bother us many times. Dr. Jyoti, are you ready?
A very good evening, sir. At the outset, I would like to thank you personally and Dr. Ishwar Singh, Dr. Ravi Meher, and the entire AOI team for having me here. And of course, I carry personal regards for you. I have learned a lot from your inputs throughout these years, and learning along with the surgeon is the best way to learn radiology. So thank you so much there. And I would like to share my screen now.
Yeah.
Sir, it doesn't allow me to share unless probably.
I will
Yes.
Have to go out first. Yes, now you can.
Is my.
No, not yet.
Not yet. Okay. Is it now visible?
Yes.
Right.
Yes, now it's visible.
Okay, so I have about 10 minutes with me to just quickly go through pre-cochlear.
Yeah, Jyoti, I know this 10 minutes is too short, but I know you will be able to make it.
I would try and make the best use of these 10 minutes, sir. So the role of imaging here is to determine the candidacy, assess potential surgical challenges, and predict post-implant outcomes. So a lot of it has been addressed by Dr. Amit Kishore prior to this talk, and we have now have we have basic ideas to how imaging can really help us. But for the younger generation here, so we have a combination of CT and MR that we can use as modalities to help us in pre-cochlear implant imaging scenarios. CT is excellent for looking at the osseous structures of the inner ear and various variants, while MR helps us to look at the fluid-filled spaces of the inner ear, and especially important for 7th, 8th nerve complex to look at the cochlear nerve, whether present, absent, hyperplastic, or good size, and auditory cortex evaluation. So as we have seen, it is the transmastoid, this facial recess approach that's most often used. Through the round window axis. So this is the plane here on CT. That's the plane of action. Through the mastoids, through the facial recess into the round window. So this is the plane that we are looking at on our CT imaging. So anything that falls in this plane is our region of interest. So when the surgeon goes through the mastoid, we need to you would like to look at the mastoids, how well pneumatized they are. Then going through the middle ear, so what is the status of the middle ear aeration? How is the status of the round window niche? And inner ear anomalies if present. In addition to these normal structures in this plane, we could have something which we do not really expect to be present here, but can be present and cause problems during the surgery. For example, a low-lying dura, certain neurovascular structures, the facial nerve, the carotid and the jugular anomalies, which could come and lie in this plane of action here. Look for cortical bone thickness, and that's where the external part of the implant is put on, and MR certainly for cochlear nerve and auditory cortex evaluation. So this is the first thing. So going quickly through all of these structures. So starting with the mastoid, you all require a well pneumatized mastoid, and we can just see all the under pneumatization or pneumatization of mastoid, the more difficult the surgery is going to be. If you have this is the normal right middle ear with air around the ossicles, and this is fluid around the ossicles, and we don't like this. So this one needs to be treated. Maybe some infection needs to be taken care of before the surgery is undertaken. Then the round window niche status. So this is the normal round window. This is the basal turn of the cochlea and the round window here. And this is how the normal size of the round window is. And sometimes this may be stenotic, as we see here. This may be congenitally stenotic, or it may be stenotic due to some problems with the bone here, like autospongiosis or Paget's disease. The rare instances there, but autospongiosis can do that. And when this round window niche is narrowed, then of course you expect that there will be issues. So this is an example of retrofenestral autospongiosis, which is narrowing the round window niche, the normal one here on the right for comparison. Dr. Amit sir has mentioned a lot of angles and lines that can predict easier surgery for cochlear implant surgeons. Now, this is one study that we did in our center, and we found that this angle between the mid-sagittal plane of the brain here, sagittal plane in the skull, and the line through the basal term of the cochlea. This angle between these two lines, the smaller the angle, the poorer was the round window accessibility. So an angle lesser than 55 degrees between these two lines, so the more acute the angle is, the visibility of round window was lesser. Another thing that we can measure on CT is the cochlear duct length. Now, I wonder how many lengths of electrodes that we have here. Probably not too many, but this is the cochlear duct length that this double oblique reformatted image on CT can help measure using this formula, because it's a spiral structure. We can't really measure it directly. So we need to make these double reformatted images and measure the cochlear length. This is an example of low-lying dura. So this is the level of the tegmen tympani, and this is the normal dural level. And this is how it falls beneath the level of the tegmen tympani and can impede your surgical access. Facial nerve, of course, now sir has mentioned that anomalous facial nerves can really, you don't want to land up in facial palsy. So this is the second segment of the facial nerve canal, and we expect it to go back and reach behind the facial recess and then turn down at the second genu as the vertical part. But here, what we see here is this is a far anteriorly placed facial nerve canal here. So this is within this pyramidal eminence lying far anteriorly, and as you would expect, it'll hamper your plane of action, and you are likely to kind of injure it if cochlear implant is planned like this. And special planes like Stenver's plane can help us delineate the entire facial canal in one plane, so it makes it easier to understand this facial anomalies. Vascular anomalies like high-riding jugular bulbs, giant bulbs, lateral sigmoid sinus, and anterolaterally displaced sigmoid sinuses again can be an impediment in your plane of action there. So quickly taking you through a few inner ear anomalies, what we follow is the Senaroglu classification 2017, and it gives us a detailed, I really cannot go through all the details here, but we shall see a few relevant examples. So as we understand, cochlear implant cannot be done when there's no cochlea or when there's no cochlear nerve. So these two are absolute contraindications. So here as a case of complete labyrinthine aplasia or Michel aplasia, we don't see any inner ear structure. We just see what is the facial canal. No inner ear structures here. So case of Michel aplasia. And this is when the vestibule is present, but there's nothing anterior to the internal auditory canal. So this is your IAC. And what we expect here anterior to the IAC is some cochlea to be present. Now here there's some deformed vestibule and semicircular canal, but no cochlea. So a complete contraindication to cochlear implant. When you have a common cavity like this, now here the vestibule and your cochlea have not really partitioned, have not really segregated well, and what we have is a common cavity. So cochlear implant, the outcome may be limited, and it will depend on how good the audiological response is before you plan a cochlear implant. Because here now, when you have a common cavity, you have a common cochleovestibular nerve. So this also most often does not divide well. And what percentage of cochlear fibers are present within this cochleovestibular nerve, we really can't predict that well. So that will depend on your audiological response, whether this patient will respond well to cochlear implant or not. And of course, has a predisposition for gusher. Cochlear hyperplasia, when the cochlea is small. So these diagrams have just made to make understanding of these CT images easier. So this is your cochlear hyperplasia, and these diagrams we have printed in our Indian Journal of Radiology and Imaging. These are all there, freely available on net. This is when the cochlea is smaller, and now the choice of electrode may change, the prognosis may change, and CH2 has again a propensity for CSF gusher. Now I'm not going to the details of how CH1, 2, 3, and 4 are seen, but the basic understanding being that when present, when detected, when the cochlea is smaller, it has surgical implications, and you all know it better than I do. So incomplete partition 1. Now what is incomplete partition? Incomplete partition is when their cochlear internal structure is not well formed. So the cochlea and the vestibule are well delineated from each other. There is a separate cochlea and there is a separate vestibule, but the internal architecture is not present. And here in IP1, it is not present at all. No modulus, no interscalar septum, and there's a widened IAC. So as you can see, you have a large gap here, no modulus. So a high incidence of CSF gusher, and these patients may have cochlear nerve, may not have cochlear nerve. MR can only tell us that, and your audiological responses can suggest, but depending on that, cochlear implant may be undertaken. Sorry for this, now this is overlapping, but anyways, this is the IP2 anomaly. I needed to have an animation here, no worries. So we have a normal, you have a normal basal turn, but the middle and the apical turns are fused. And what is Mondini's triad is when you have an accompanying enlarged vestibule and an enlarged vestibular aqueduct. So that's a complete Mondini triad. But what is interesting about IP2 is that they always have a cochlear nerve, so cochlear implant is a good option there. As per Senaroglu's literature, all 100% of cases of IP2 have a cochlear nerve within them. So, and I also have found no exception, so I'm sure. So that is one thing that I find really interesting, that IP2 onwards, IP2 and IP3 have their cochlear nerves intact. Cochlear aperture hypoplasias. Now this is the normal cochlear aperture, and this is the stenotic cochlear aperture. So when the cochlear aperture is stenotic or completely aplastic, completely replaced by bone, that means it's the cochlear, we expect a cochlear nerve anomaly. So when it is hypoplastic, the cochlear nerve could be hypoplastic or absent, but when the cochlear aperture is completely replaced by bone, now this is completely aplastic. So these are signs on CT that can tell us that the cochlear nerve is abnormal. And mind you, this is one of the most commonly under-recognized anomalies. So we generally forget to look at the cochlear aperture. So I make it a point to pay special attention there on CT, which is an indirect evidence of your cochlear nerve on the MR. Of course, with normal cochlear aperture and normal ISC, cochlear nerve may still be absent, but when this is present, you expect a cochlear nerve anomaly. And this is how we see the sagittal oblique images, the dots of the cochleovestibular nerves. And what we are expecting here is another dot here beneath this dot here. So we are supposed to see 4 dots, 1, 2, and 3, 4. These 3, 4 are combined. That's all right. We see that very often. So 1, 2, 3, 4. The second dot here goes missing, and that's the absent cochlear branch. Labyrinthitis ossificans is another challenging condition to maneuver, and we have all heard about it from Dr. Amit sir. So yes, this is one example of extensive labyrinthitis ossificans where cochlear implant may be particularly challenging. So algorithmically, if there is no cochlea or no cochlear nerve, of course, cochlear implant is contraindicated. In cases of common cavity, cochlear hyplasia, IP1 anomaly, cochlear implant is possible. Outcome is variable depending on whether cochlear nerve is absent, present, what is the other clinical scenario. And in IP2 and IP3, cochlear nerve is always present. Of course, CH2, common cavity, and IP3 have an extra risk of, and IP1 have an extra risk of gusher, which we are all aware of. And when there's cochlear aperture hypoplasia, do an MR and see if you can look for cochlear nerve. Of course, audiological responses also aid. Radiology is a part of your complete evaluation, and the choice of surgery can then be decided, like whether a cochlear implant is possible or not can be decided. But when cochlear aperture is aplastic, then cochlear implant cannot be done. So imaging is the key to ensure accurate counseling, uneventful surgery, and delivering realistic post-operative outcomes. With that, I thank you for your kind attention.
Thank you very much. Am I audible?
Yes, sir.
Thank you very much, Dr. Jyoti, for giving us a very nice account of normal and abnormal situations we come across. As we all know that around 80% of the cochlea that we see is generally normal. It is roughly 20% which are the cause of concern and which create problems, and we are supposed to keep that thing in mind every time we read a CT or an MR of temporal lobe. Thank you very much, and I wish you to stay back with us because there would be some queries from our members. So I move on to the next item of the panel discussion, which is about the present times, which is COVID times. So COVID times is definitely bothering each one of us, and as we all know that except the mucor cases, we are not doing routine surgery, most of us yet, in a government setting at least. I don't know, Dr. Amit Kishore would be doing non-COVID, all kinds of other operations. But we all know that the second wave has also not gone yet, and third may emerge. So my query to our worthy panelists is that should we do a cochlear implant these days, or we should defer? And if we want to defer, how long we would like to defer? Dr. N.N. Mathur is there. Kindly throw some light on this.
So thank you very much. First of all, AOI Delhi, Dr. Ravi Meher and Dr. Pasi for inviting me to this panel. You have very rightly said that the biggest surgical mortality which has happened in last 1.5 years has been on the issues which are very, very elective. And cochlear implant is one of those very elective surgeries that we do. However, because it is in children and we never expected this pandemic to last that long when it started, now we are 1.5 years. So meaning thereby that the children have already waited for 1.5 years and they have gone, every day is counting, you know. And those who are newborn, they have become almost 1.5 or and those who are 3 years, they are nearing 5. So they are going beyond the limit, age limit. So it has become an emergency, so to say. We have had our personal experience in this regard. We had closed down at Lady Harding the cochlear implant, but between first and second wave, we got some window and they did. We had done 5 cochlear implants. And then the second wave was there. Then again, they were stopped. And now we have again started. And we have done around 6 in last 2-3 weeks. So, I would like to share one incident, what happened. One patient was started on the cochlear implant with the RT-PCR negative report. And anesthesia people, they insist on the morning report of, the report which is very new, a night before the sample sent. And that after the case was started on the previous report, which was 2-3 days before, in the middle of half an hour of surgery, the report came in that the RT-PCR is positive. So there was a confusion that what to do now. Surgeons are at risk, and anesthetist is at risk, and the surgery is very near to the airway, and you are there for 1.5-2 hours. So I decided that it should be stopped, and it was stopped. And then the patient was taken up 2 days back again. So this was our experience of one case which created problem. However, I think you will discuss it later, but the COVID has not created that much of a medical problem in cochlear implantation as much as logistic problem. And that how to do, when to do, all those things. Having said that, we have got some anecdotal case reports, and we in our OPD also we have seen very few. Not to make any opinion about it, but some cases of unilateral or bilateral sudden sensory hearing loss, and with the Covishield, some cases coming up with the hearing loss. They have been reported and gone to the AFRI, and luckily we have got the AFRI chairman in our national chairman in our institute only. So I keep meeting him quite often, and we have tried to tell to him that this is one of the problems that he should look into. That is this is the problem all over India, or it is our problem only. So these are some of the issues which have to be, looked into. They are we are in the midst of some disease of which we do not know much about. So we do not know how it will pan out, or maybe what will be the long-term effect. There had been some reports that in the COVID patients, some of the implants have failed. 2 of the reported cases are already there, in which there was some inflammatory, because of the inflammation in the inner ear, it affects the fluids and the constituents, and it causes the implant failure. And so much so that some of the channels have to be put off.
All right, Dr. Mathur, I agree with you that we have already lost more than a year waiting for doing these elective surgeries, and we know the adverse effects of delaying the surgery. We all know that. So it appears that you are in favor of going for surgery even during COVID times. So
yes.
my question to Dr. Amit Kishore would be that if at all we start, first of all, I'd like to know what was his reaction during COVID times about doing elective surgeries, and if at all we do it, how we move and how we prevent complication arising out of a situation. Dr. Neeraj Mathur has just narrated the RT-PCR came positive intraoperatively. So how to manage that situation? Was abandoning the case a right step? Is Dr. Amit Kishore there?
Yes, I'm here, sir. I'm here. So the answer to the first part is that yes, during the during the peak of the COVID, we had stopped elective surgery because even the hospital was not accepting COVID elective surgery, and it was appropriate that all resources should be directed towards COVID patients for their medical care and then the surgical care where necessary. And I understand that in the government scenario, the pressure is even higher to be able to do that. So, but even in our setup, we were not performing cochlear implant surgery or any elective surgery during the peak.
Are you
of
doing
COVID.
now? Have you started
Yes,
now?
so we have started now. We've started in the last month or so. We've already started. We have done a few patients, but I think
Any extra precautions you are taking?
So what we are doing, sir, of course, we want that they should have negative RT-PCR. We've had one situation where a child first of all, we check the RT-PCR well before the child is admitted. So we want a recent RT-PCR 48 hours prior to admission. And that's what happened. So this child family was negative 10 days before, and then on the immediate pre-operative, it was positive, and we canceled the surgery. But we don't admit that child because we usually admit on the evening before or the morning before, and we want the fresh RT-PCR 1 day before. And that came as positive, so we canceled that surgery. He was not on the operating table. The second is that during the surgery, of course, the risk is not only to the child, but also to the staff. So we use a drape, we use a C-arm drape or a flexible drape to actually create a tent, because there is evidence to show that viral particles are found in the aerosol that is generated from the drill, because there is connection with the eustachian tube. So we always create a tent so that all that aerosol is captured within the tent and is not flowing into the atmosphere in the OR, and therefore the staff, apart from everything else that we all do, that's an additional precaution that we take. So this is, I hope I've answered the question.
Have you also heard of a complication like device failure or sensory hearing loss? Or it is just a coincidental finding that it was so found during the pandemic?
We've all seen patients who've presented to us with tinnitus and sudden sensory hearing loss. It's very hard to say, is it due to COVID or is it just the standard sudden SNHL that we have always been seeing? So that's very hard question to answer. I don't have an answer. We've not seen any cochlear implant related complications so far, as Professor Mathur has mentioned. But I think we'll have to look at the literature and see. I've not come across that.
I think we should also, we all should agree to this, that we are not expecting COVID to do any extraordinary or a specific damage to our cochlear implant surgery, apart from the fact that we can contract infection if the baby is infected, or if we do not keep all the precautions, like you are creating a dent. You said it's an extra precaution to avoid aerosols. I think we ENT surgeons are one of the most vulnerable people to contract infection, COVID infection. So we have to take into consideration all the possible means before we start even examining a patient. Let's move on to the next. Yeah.
Sir, can I add something, sir?
Yes, Ravi.
Sir, this COVID report, which we actually get 48 hours before the surgery. I mean, I have discussed this with the microbiologist in our hospital, and according to him, the patient is COVID negative after 2 to 3 weeks of infection,
recovery,
and after that, whatever report comes positive, it is because of the dead virus which is there in the nasopharynx, and this dead virus can be there for 4 to 6 weeks after infection also. And what RT-PCR does, RT-PCR will catch hold any RNA particle which is there in the nasopharyngeal secretions, and it will amplify and give a false positive result.
That we all know. See, Ravi, a point here is that patient should be RT-PCR negative. It doesn't matter if we, in my case, I became RT-PCR negative on 4th test after each week, 3 weeks after getting recovered.
Right.
So it took me 6 weeks to become a negative.
Right, sir.
There is no harm if you go on to 6 weeks.
My point is that even the RT-PCR is negative, the patient is non-infective. Like we are operating lots of mucor cases, and in fact, in last 1 month or 1.5 months, we have operated more than 125 patients of mucor. and many times this problem arised. Patient was RT-PCR negative, but during the surgery, RT-PCR report came and it became positive. So we continued with the surgery.
So you explain.
Taking all the precautions. Yes,
See,
we continued with the surgery, and then
if we go into the pathogenesis of mucormycosis, most of our patients who are having surgical indication would be COVID negative. They would have suffered from it, and they were on the path of recovery when they had this fungal infection. So, but they can still be tested positive.
Yes,
so that is there. This can happen. But in case of cochlear implant, if we must ensure that RT-PCR is negative, even if it is false positive, even if it is false positive 3 weeks after contracting infection, let us wait for another 2 weeks or 3 weeks. Your anesthetic is not going to agree. Your staff nurse is not going to agree. So it's better we stick to that decision of RT-PCR negative at least 1 day before surgery. So I move on to the next query, which is about the for the knowledge of our youngsters. Somebody, Dr. Rakesh, may tell us about what are the various brands and their models available, and what is happening to our own indigenous implant. Dr. Rakesh.
Yes, sir. So first, I will tell what we are using at our hospital.
Yeah.
Because being a government sector and the rate contract, so what we had first time rate contract was nucleus, and we are using straight implant.
That was as the basic rates, the cheapest in the country. I remember.
Yeah. So that was the one. And then when after 2 years second rate contract came, then we had this thing metal. So metal implant was the advantage with this metal implant was it has various types of the electrode array one can choose from, and they were not changing the cost. So we got this Sonata implant. With whatever electrode you want, you can have. So the standard electrode, the medium size electrode and compressed electrode, only thing was the length of the electrode. So the standard was 31.5 millimeter. The compressed was 15 millimeter. Beside that, now the Cochlear have also come out with the different electrodes. So for the higher implant, they're giving Cochlear implant 532, which is soft. And the modular hugging electrode. The cost is a problem, and supposedly it sets into the very near to the Cochlear now. So the hearing improvement and the current level required to stimulate the nerve is less, and supposedly battery lasts longer, and the hearing improvement is much better. So the major electrodes are used as straight electrode, and in a particular situation, like if it is like this cochlear ossification or the 1.5 ton, one can use the compressed electrode, and maybe the double array electrode. One goes into the basal tongue, second goes into the second tongue, anterior to the this oval window.
Yeah. Hello.
Hello.
Yeah, Dr. Kesh. Any other brands? Would you like to talk about Digisonic, Neurotron?
Yeah,
these are also available.
Yeah, Digisonic. I have done I think 2 in this our national program. The electrodes are almost similar to this thing, metal electrode. It's a little thicker and easy to put.
Yeah, you only need to apply screws. You don't have to make a well in this.
To screw. The other implant, I don't have experience. We have some experience with the nucleus contour advance, which are the first one which came with this stellate. So metal implants are also there, electrode array, but I don't have experience with them.
So deliberately, I'm not going to ask about the preferences of the brands because of the obvious reason, but can you throw some light on the latest position of our Indian implant, which was being developed by DRDO?
Actually, AIMS was one of the center which was chosen to do the implant, and Dr. Alok was involved, and he has done few cases. So it has the straight electrode, and supposedly initial outcome is good.
So is it available now? Is it freely available? Is it in the market?
I don't think it is easily available in market. It has been given to few of the medical colleges, I think 5, and 5 implant each were given, and after that only this marketing will start.
Any one of my panelists would like to throw light on the indigenous implant? Any experience, like Dr. Rakesh has said?
Dr. Pasi,
yeah.
Sir, Ishwar here.
Yeah, Ishwar.
I attended one of the meeting with Dr. Alok about this indigenous implant, and this thing task is given to a company at the Indore, and we happened to visit the site, and we saw the thing, and it is named Sarwan, and they were supposed to give 50 and this thing implants to various colleges which have been earmarked to do this trial. And this all was before COVID happened, and I saw the manufacture of the implants, and they were almost ready. And I don't know after the COVID what it has gone. Well, what is the status right now?
Okay, so we are. That means we are quite close to have it in the markets now.
1 lakh.
That is why I'm more interested in talking about indigenous implant, because the cost will always matter to us in India, everywhere in the world. But of course, in our country, we will have the cost factor always very important factor for all of us. Especially people working in government sector, people taking the financial aid from the government. We will always prefer this if it goes well. Let's hope so. So time is limited. I'm not going to. Anybody else would like to comment on the models and brands out of our panelists? Dr. Shalab. Dr. Shalab?
Dr. Pasi, I
Yeah.
don't have any experience with the indigenous implant.
Which one are you using?
We do all the 3, the Cochlear.
Your volume is, can you just increase your volume?
We do all the Cochlear devices, Medel, and also advanced bionics. Depending on what the patient chooses, we give the choice to the patient, and the relatives, the parents are able to choose the one that they like, or the one that they want or they can afford, and that's the one we implant.
So my message is that we have around 5 brands available all over the globe, and the 6th one, our Indian, should come up, and in coming days we should be using our own indigenous implant more and more often. Next, Dr. Shalab, again I will continue with you about the technique. We have been talking and fighting, and not fighting, I mean arguing. So much about which one is the better technique, the conventional posterior tympanotomy or a Varia technique. Which technique you would like to advocate, Shalab?
I have to, there's a disclaimer, is that I do, the only technique that I
Please unmute. Ravi, jara unmute karao. Yeah, yes, Shalab.
So I said there's a disclaimer, is that the only technique that I perform is the posterior tympanotomy. But I would say that over the years now, it's almost 20 years since the implant program started, and we did the first implant at Gangaram. I think that I would want to look at a different technique only if there was a particular reason for doing so, as in if I had difficulty getting an electrodes into the cochlea, or that there were complications related to the technique that would cause me to want to change. But that has, over the years, I haven't found a reason for that. The posterior tympanotomy is a good technique for an otologist to learn, because it also teaches any learning otologist or a young otologist about the anatomy of the middle ear and the inner ear, and it gives us gives the person a chance to become a better otologist in time. The other thing is that whereas the Varia technique is concerned, I have a lot of friends and a lot of colleagues who are using this technique. The only thing that I would caution about is the fact that I've had the chance to see a couple of the canal extrusions of the electrodes, in some patients, and also I have knowledge of some facial paralysis that have occurred in the Varia technique. Now the thing is, maybe it's because it's a learning technique. Once a person is experienced with this, maybe they are able to avoid the complications. But having seen the surgery being performed, I think that it's very difficult to be always sure that the the pericanal passage is separate from the canal, and that it doesn't, break into the canal at some places with the.
So the facial nerve is more at risk during Varia technique.
Well, the only thing
than in the posterior tympanotomy.
In a Varia technique, until the end of surgery and the patient wakes up, you don't know if you've injured it. But I mean, I would say also the canal extrusions are very worrying. Now, if I had a technique, let's say posterior tympanotomy, and if I had a extrusion every 100 cases or 150 or 200 cases, then I would really go back and think what is the problem, because I can't afford a single extrusion in my practice, at least in private practice. And it's so difficult to convince a patient or to talk to a patient and tell them that you could have a particular complication. And I have a explantation this coming week for a child who had a posterior Varia technique surgery, and the electrode has been lying in the canal for quite some time. So I would say that any technique which has that potential complication, that I may actually have to explant an implant because a technical problem has taken place, I would really think very carefully whether I really wanted to continue with that or not.
Thank you, Shalabh. About the Varia technique, my personal experience is that we started with Varia technique only at Maulana Azad Medical College in the beginning, long time back, when Professor Trifon, who is the founder, who started this technique, was there with us to supervise. Dr. Agarwal and me were there. I don't know, Ravi was there in the department as PG at that time or not. So this Varia technique we started. I found it technically little difficult, and also that possibility of extrusion of the electrode is very high, no doubt about it. And also the risk of injuring the facial nerve are there. These two things are there. So we also took up our posterior tympanotomy, the standard technique. But I would like somebody to say some good words about Varia technique also out of our panelists. Whom can I ask this? Ravi, would you like to say something in favor of Varia technique?
Sir, I don't have any experience of Varia technique, and in fact, I have learned from you only, and we are doing posterior tympanotomy for almost last 15 years in the department. We have not done any Varia technique. And I agree with Dr. Shalabh about
Dr. Amit Kishore showed us one case. He had to do it because of the contracted antepost, jugular valves, the lateral sinus thing. But is he there to comment on Varia technique?
Yeah. I'm there. So thank you for that. I don't have experience with the Varia technique per se, because in that, as the technique describes, you create a blind tunnel. So my preferred technique for the last 20 years has been the posterior tympanotomy. Works well. I can exactly see what it is. It gives me the flexibility to insert all types of arrays. I can, you have difficulty in the perimodial arrays going through a tunnel. I don't think that is very feasible. And Shalabh, and you have already alluded to some of the issues. But what I showed you was a suprameatal, was a different route, which, as I said, maybe in 1800 or so, I've had to use maybe 4 or 5 times. But that again is under vision, because we are not going in a tunnel. we remove the incus and create a space, and I can see exactly where it's going. There is a good bridge of the posterior canal, so I'm not going to have an issue with.
But since you had to raise the tympanometal flap, there is a possibility of the electrode going close to the undersurface of the tympanic membrane and subsequent extrusion.
That is true. It's still like in the varia, you're going just under the annulus. Here we are still going under the scutum, and then I also reinforce, which I didn't show, but we also reinforce that tympanometal flap with some extra fascia or cartilage to provide that extra. I'm very uncomfortable about lifting the tympanometal flap in cochlear implant, but this is a situation where, and if you're really pushed to the corner and you have to do something, then as I said, it's very, very rare. 5 in 1800 is a very rare situation that I've had to do. Maybe other surgeons find other ways. You can do other ways as well. Like I said, it was just to show people that there is an option that you have, but you have to take care. So it's not a.
So incidentally, I feel that most of us sitting here today do posterior tympanotomy approach only. And varia technique is also being followed. It's not that varia technique people are not doing. My message to our young budding cochlear implant surgeon would be that both the techniques are okay. Varia technique has its own advantages and disadvantages. It is the question of mastering a technique. Whatever technique you take up, you should master that technique. You should do it on cadaver again and again and again and again. That is the key. Whatever technique you follow, you should be master of that technique. And if you keep doing some technique, maybe a varia technique, you will be a master sometime, someday. So it is a question of your own confidence, your own ease, that you choose one of the two techniques, and you can choose either. So we can go to the next one. We have done a study of use of photoendoscope long back. Ravi, would you like to recall your experience of starting using photoendoscopes during cochlear implant surgery? How much does it help? Is it a must, or you can do without it also?
Sir, actually, when we started cochlear implant in our unit, we started with this separate bony cochleostomy. But later on, we found that in the literature also, and everybody started doing round window insertion because it is more beneficial and more physiological. So finding a round window initially was very difficult. Like when I started doing a posterior tympanotomy, and sometimes what happens when we have not removed the complete the middle part of the bone in the posterior tympanotomy, the round window visibility is sometimes difficult with the microscope. And in initial cases, when we started, one of our resident, in fact, she told us that let's introduce an endoscope and see if the round window is visible or not. And we started using endoscopes, 1.9 millimeter endoscope through the posterior tympanotomy to visualize a round window. And in fact, it gives us more confidence that yes, we can see the round window niche area very beautifully, and then we can modify, or we can just enlarge the posterior tympanotomy further to have a good view of round window and insert the implant through the posterior tympanotomy using a microscope. So intraoperatively, we can use it's an adjunct. You can use an endoscope to visualize the round window niche area, and it is very useful, especially in patients who have malformed cochlea. So in those patients, this round window might be very, very hidden, or it might be very posteriorly placed, where the angle of the microscope is not good enough to give a full view of the round window membrane. And we also did a small study to look at the grading of the round window via endoscope and microscope. And we found that the endoscopic visualization of round window improved drastically as compared to the microscopic view. So that is a useful adjunct for beginners when they have problem in finding the round window membrane.
Very right. I would like to ask the experience of Dr. Shumeshwar Singh, then I'll come to Shalabh after that, about use of endoscope, photoendoscopes. Dr. Shumeshwar.
Yeah, hi. Thanks for asking me. So, I'll be honest, I stick to the very classical posterior tympanotomy approach with a microscope. I have never sort of ventured outside this happy zone
So you must have
endoscopes at
come
all.
across very highly posteriorly placed round window niche.
So you know,
and,
I mean, I'll be honest.
anteriorly placed facial nerve.
So in the beginning of my career, like sort of 10, 12 years back, I used to be in that position more often. And now I feel as I've got better and better at the technique, somehow that confusion is not, or that difficult position is not so often. And I think it is all down to a very happy, good cortical mastoidectomy, very good exposure, really thinning the posterior canal wall down, and making sure that you are very flexible with your microscope as well. If you can use your microscope, if you've got a very flexible microscope head, you can turn around and you can make yourself super comfortable, not just be confined to patient position, or fixed position. And that has, at that exposure only, that incidence only once. But but I feel so comfortable with a good microscope that I feel that, and I sometimes feel, especially in my experience with training, that people do not, a lot of young surgeons as they're coming along, they do not use the microscope and all its features, the flexibility of the way you can reposition. And if you use it enough, you will you will not need much more. But I totally appreciate that an endoscope must be adding value, especially in giving us more information in difficult situations.
Okay, but Dr. Shalabh?
Yeah.
Yeah. Will you like to say something about the use of photoendoscope?
Yeah, in my experience, the round window niche is usually not visible when it is more posteriorly placed, and the visibility of it is limited because of the one could be leaving extra bone over the facial nerve and not taking it down enough, but the other reason, and the more common reason, is not thinning the posterior canal wall enough. And if the posterior canal wall is not thinned enough, especially the younger the child, the more chances of it being little posterior placed. Then a lot of times it seems to be that the round window is actually not seen, or it doesn't seem to be there, but it's almost always there. Sometimes if the patient has had some middle ear effusion or infection in the past month or couple of weeks before the surgery, then there can be edema of the mucosa. And in those cases, if you can see the stapes and you can see the area below that, just a cotton pledget, gel foam pledget with adrenaline for a very short duration of time will usually decongest the mucosa and give you a much better view. Sometimes the round window niche, if you see the older patients, can also be obliterated because of mucosal folds, sort of because of past infections maybe, that they seem to be covering the area. But then using a needle, it's usually possible to separate those out and to actually identify the niche itself.
So, according to you, you also don't need to use the autoendoscope often.
No, it's almost never, I think almost never that the round window niche has not been found. But an endoscope would be a good instrument to have, especially if you're in the early phase of your training or the career, that if you have difficulty or if you think you're not able to find the niche, then putting an endoscope would definitely give you a much end-on and much closer view. And the chances are you will be able to see where the round window niche is and then tailor the approach to that so that you can approach it. But almost always, I think leaving too much of bone on the posterior canal wall is the main reason why the round window niche seems to be difficult to visualize in most of the cases.
I totally agree with you, Shalabh. I also believe that thinning of the anterior rim of the posterior canal wall is an issue. If we thin that anterior rim of the posterior canal wall, for which you will have to go inside, right inside the middle ear cavity with your drill and do it inside out type, and reduce the height of this ridge of bone over the vertical portion of the facial nerve canal, you will invariably find the round window niche. but sometimes in a displaced cochlea, we feel that we are not sure about the proper visualization of the niche. There, I personally feel that you are very happy using a 30-degree 1.9 or even 2.7 mm auto endoscope. Dr. Amit Kishore has some experience.
No, sir, I've never had to. I would agree with all of what all three of you have said. I think it's all about the little attention to the little fine details and flexibility of the microscope, thinning the canal and down the bone. I've never had to use an endoscope, and I've never had to change my technique because of a posterior displaced round window or a small, moderate sized cavity or anything like that. I've always done it through the posterior tympanotomy and microscope, just those little things that you all have discussed.
The use of photoendoscope is only to visualize the round window niche.
Yeah,
It's not nothing more than that.
Yeah, I've never had to resort to that. That's just my experience. I think it's just something that we've all sort of got comfortable with time and experience.
Dr. Rakesh, would you like to say something on it? Dr. Rakesh. Rakesh, are you there?
Can I add something?
Yes.
Actually, sir, what I want to add is that probably when we all started, we started with a cochleostomy. So that time the exposure of round window, especially in the beginning, was not that much of the question. But as all panelists say, with experience, and Dr. Shalab has very nicely said that thinning the posterior canal wall, that is one factor. Second is all otologists in the beginning, they are afraid of facial, so they tend to go away from the facial and drilling more anterior. So the trick is that you identify the chorda tympani, then you start drilling back and just leave a very thin bone over the facial nerve. So if you do that, then obviously you will be able to see the round window niche.
Dr. Shalab wanted to say something more.
I just wanted to say that Dr. Someshwar, he was absolutely right when he said that using the angle or the angled objective of the microscope and tilting the microscope. I've had so many of my people whom I'm training, they keep asking the anesthetist to keep shifting turning the table to the right, turning the table to the left, opposite side karo, aage karo, piche karo. But the thing is that usually it's, if you are able to use the microscope properly and you learn to use the microscope angles properly, then you don't need to shift the patient, turn him right or left at all. You can just get all the angles from the same position in the static. And I think he's absolutely right, because if you can't angle the microscope properly, I've had people have difficulty even identifying where to put the grommet in the myringotomy because they're not able to see that area.
So the message is very clear that use of autoendoscope can be useful in situations when you have an extremely posteriorly placed round window niche, you have a superficial facial nerve, and you have a displaced cochlea. And the beginners, like everyone here is an experienced otologist, they don't need the use of any assistive device, but autoendoscope will definitely save you from making complications, especially injuring the facial nerve or dislocating the ossicular chain. If you use autoendoscope, like you tilt the microscope, you just put in the 1.9 or 2.7 mm autoendoscope, and you will be sure that yes, it is the round window niche, especially when the round window niche is small, it is overhang by the bone, and it's not very clearly visible. And sometimes even the IS joint, which is the hallmark or the tendon of the stapedius muscle that we must identify each time, is not identifiable. So use of autoendoscope will definitely ease your life, especially the beginners. They should not hesitate using autoendoscopes. Thank you. We'll go to the next issue, which is to be shared by most of us. Jyoti has already told us about the radiological aspects, and I have got a few of those conditions which were given to us, and I would just like to share some experience of our worthy panelists. I will start with Dr. Amit Kishore. What will we like to do in a case of cochlear aplasia or labyrinthine aplasia, Michael's aplasia?
Right. So in this case, it's quite obvious that a cochlear implant is not possible in this child. So in this situation, we give the parents two options. We give the parent the option of either looking at an auditory brainstem implant with all the caveats, the limitations, the expected outcomes, the difficulties in mapping, and long-term limitations in schooling, etc. And we also discuss with them the option of enrolling into deaf school for deaf education, because the child does need to have language, and an ABI is not going to be, is unlikely to be able to give a congenitally hearing impaired child adequate language through audition, and therefore they're going to, in any case, be reliant on total communication. So they might also look at sign language as an option to develop language. So that's a very difficult decision. It's long counseling, multiple meetings, but these are the options. These are the two options they have.
Dr. Mathur is there, Dr. Neeraj. Your comments on the next condition of common cavity, which we come across quite often. Dr. Mathur?
Yeah. So as has been very aptly and very elaborately dealt by both the radiologists, Dr. Jyoti Kumar, as well as Dr. Amit Kishore, the common cavity problems in IP1 and IP3. These problems you do see off and on, as they are not as common as to be seen almost every month. But yes, you'll be seeing them quite frequently um, uh, if you are a regular cochlear implant surgeon. And,
will you like to go for the surgery, or you will have some reservation?
Yes. The common cavity thing will need to be operated upon.
Any difference of opinion amongst the panelists regarding going for surgery or not going, or if at all not going for surgery, in what specific condition? What other findings should be there for you to not go for surgery? Yes, Dr.
I think that, as Dr. Jyoti has rightly mentioned, one of the things that we have to look for is the auditory nerve, the presence of an auditory nerve, because you can have that association. You can have, we've all seen aplastic nerves even in absolutely normal cochlear anatomy. So if you have both a common cavity and an absent or a hypoplastic nerve, it's a double whammy, and that is going to affect the outcome. The second thing to keep in mind is that we've got to be sure that we are looking at a common cavity and not a cochlear hypoplasia with a vestibular dilatation. Dilatation. And Dr. Jyoti again has mentioned that the cavity, if it's accessed or centered around the axis of the IEM, it's a common cavity. If that enlargement is all posterior to the axis of the IEM, you're likely dealing with a cochlear hypoplasia with an enlarged vestibule. So you have to do that, rely very heavily on what your audiologist tells you. The outcomes are going to be compromised, but if there is a reasonable auditory nerve presence, reasonable audition through hearing aid trial, etc., then it's worthwhile giving that child a chance, provided the family is well aware of the expected outcome. So we would give them that chance, because that will still probably be better than an ABI, for example.
So pre-operative counseling to the parents would be a very, very crucial thing in these situations. About the cochlear hypoplasia, Dr. Jyoti said that you are likely to find hypoplastic auditory nerve as well as facial nerve, maybe. So what will be your approach, Dr. Shalab, about such a situation?
Sorry, Dr. Pasi, can you repeat, please?
Cochlear hypoplasia. Here we are expecting hypoplastic auditory nerve also.
Yeah. The cochlear hypoplasia, the implantation is usually possible. The only problem usually is with the length of the implant, the length of the electrode, because the length of the cochlear canal is shorter, and we have to remember sometimes that we should not try to over insert the implant, over insert the electrode, because there will come a time when, say, once you've got some of the part of the electrodes in, there may still be some left outside, but there may be a bit of a stop, in which case we shouldn't force it inside and should remember that that is enough, and trying to push in extra electrodes may actually cause damage to the electrode itself. And wherein the cochlear nerve is present is usually always the best condition. We're happy to see it, but sometimes when the cochlear nerve is not seen, it is possible that it may be running around the edge of on the side of the canal itself, hugging the canal, in which case maybe because it's not surrounded by CSF, you may not see it. But if you have pre-op thresholds, which do indicate the presence of a nerve, then you can still go in and do the implant. The problem would be if it's a hypoplastic nerve, then you have to be very circumspect because hypoplastic nerves, in my experience, our experience, they haven't, the children with hypoplastic nerves have not done too well after implantation, because I think the nerve suffers from fatigue or does not pass the signals on to actually get a good response from the child.
Dr. Someshwar, your comments on hypoplastic nerve.
So, when it comes to a hypoplastic nerve, it is very clear that we do not know what the outcome is going to be. We hope there will be a reasonable outcome, but we should all be ready for a poor outcome. And I make that very clear to the parent that the outcome can be poor. However, given the paucity of other options, usually cochlear implant surgery is well worth it, because most of us do not face too much of a challenge handling other complications like CSF leak. But I think one point that has not been covered so far, which I am very keen on, is to discuss with the parent that there are many other options for a deaf child. There aren't just the two. It's not like cochlear implant with a super outcome and verbal oral speech is only one option. A deaf child has the option of enjoying audition, so he can hear sounds. He may only develop partial speech and therefore may need to develop sign language or other modalities of developing speech, some of which are in experimental zone, and I'm working on some of them. But there is the option of getting a cochlear implant, which gives you partial hearing. It does not allow you to develop super clear speech, but that doesn't mean it's not useful. So the fact that you can still hear a lot in life will be very helpful and will help the child in his development of language. But it may be that he may have to still develop sign language in addition to hearing. And I feel that this is not covered enough. But it is a fact. There are many, many more people in the deaf community who use sign language than who get cochlear implants and develop oral speech. And oral speech is not everything. Partial hearing is also a good addition. If this counseling is done right, then even someone whom we operate very late, who enjoys hearing but does not enjoy clear speech, will consider it a good outcome, provided your counseling was spot on.
I shall go to Namita to ask this, her experience with outcomes in such situation. Namita.
Yes, sir.
Yes, Dr.
So
Namita.
Yeah, can you hear me, sir?
Yeah.
So we have a big series of implantees with hypoplastic nerve and hypoplastic cochlea. And with them, we have to work very closely pre-implant, because we have to see whether they have any auditory, especially in cases of hypoplastic nerve. We do an extensive hearing aid trial wherein we observe the child and we call it as a diagnostic therapy. We enroll them in a therapy program and we kind of see whether they are giving. We look at the aided thresholds with a hearing aid, and particularly in the mid frequency. High frequency, we generally don't get it. Low frequency, you can get a vibrotactile. So we look at the mid frequencies, at least 500, 1K and 2K. And if there is some auditory response, even at a very higher threshold, we kind of agree and with the surgeon to take them for cochlear implant, and we expect some results. We also rely heavily on electrophysiological test. Post-operative, we do EABRs, and we see if there is an auditory response or peak 5 is visible post-implantation through cochlear implant. And we also do intraoperative EABR, wherein we see the results in hypoplastic cases. And then we make a map. So making a map is a challenge in these kind of children and adults.
I just wanted you to just sum up in terms of outcome. What is your experience in terms of outcomes?
So outcomes are compromised. We can achieve verbal speech in these children, but with the help of the therapy modality cannot be or should not be only auditorily, and it should be aided with other visual cues, and oral speech is possible in these children with the help of visual cues.
I think Dr. Amit Kishore has already covered about IP 1, 2, and 3. I will just go to the next part of our discussion, that is about training part, which I will request Dr. Someshwar Singh to give his view in a short while. I mean, within the time which has been allotted to him.
Yeah, thanks.
We are running short of time.
I understand. So I'm going to skip the slides. The slides don't have too much, but I'll just sum it up here. So I'm involved quite closely in cochlear implant surgical training, and I will accept that my ways have been a little out of tradition. So there are two ways I do surgical training. One is the course. I run a course, which I've done about 7 times so far, where 4 surgeons attend the course at one time. The course is not a usual course in that it is very, very intense. We go through the steps millimeter by millimeter, and we spend about 2.5 to 3 days mainly on surgical steps. And we use fake-on temporal bones because I don't have access to an anatomy department, and it's in a private sector, in a private space. So, but fake-on bones, although expensive, are very useful. They allow me to get that core concept about the way you do a mastectomy, the way you develop a posterior tympanotomy, and the way you orient yourself to the cochlea that you can't see, but you need to implant. And they are not perfect, but they are good enough, but they're expensive. So the course is a very useful way to train. However, if the course is not followed by actual surgery, then those surgeons who went on to do surgery did very well. But those who did not go on to do surgery, then of course, the course becomes historical, and I'm not sure how much benefit it is. But the second way that I'm involved in training is through surgical mentoring. And this is where I accept that my ways are slightly not traditional. Now, when someone starts a cochlear implant program, invariably the conventional way is for me to operate and for him to assist a few times, and then more assist a few times, and do a few steps, and then finally do the full surgery. But I feel that I don't have the luxury. And if I insisted on all these steps, then I would never complete training in some of these surgeons. And now I've done this surgical mentoring more than 100 times, like literally, I'm not exaggerating. And I have allowed the surgeon to operate A to Z. Now, he operates even the first time I've met him. And this is where I say I'm slightly crossing tradition. But the difference is that this is a surgeon who is very experienced in middle ear surgery, in mastoid surgery, maybe stapes, definitely tympanoplasty, ossiculoplasty, mastoidectomies. And he has seen a lot of live surgeries. He has seen a lot of videos. And I feel that I'm comfortable for him to straight away start out with doing the full surgery. I only stand as an observer, watching him through the sidearm or looking at his steps on a monitor. Both of them are critical.
But you are always physically present when they start.
Yes. No, I haven't done it remotely yet, but I'm always physically present, but I'm not scrubbed. And I feel that if I talk my way through every step, and provided he has also got the attitude to listen to me, and he must, if he doesn't, then there's a problem. Then it's like he's got all the skills. And I think a lot of surgeons in India have all the core skills. It's like they know how to drive, they just don't know the way. And they don't know the finer tips. So I'm able to walk them through all the steps, including implanting the electrode. Does your
temporal bone give the soft tissue feel to the
no
learning
students? Only drilling. No, I mean, but what I'm talking about now is actual operating on a patient, and even though they are doing it the first, not all the surgeons I'm mentoring have attended my course. In fact, a very small percentage have. So the course has only happened 7 times, so it's only about 28 surgeons who have attended it. But even if they are operating the first time, I'm comfortable with them operating, and I'm, of course, watching them very closely. So it's like my head and their hands, but it brings in a lot of clarity in their understanding of how to do the procedure. And in about 10% cases, I have to scrub because maybe the progress is too slow. But in 90% cases, looking at the sidearm and guiding them and looking at the monitor and guiding them, I'm able to get them to complete a surgical procedure. Of course, the challenge here is they shouldn't get too confident, because I suspect if I'm not there, they may not be able to complete. And hopefully they have the insight to understand that, because there are things that they may not be able to register given that they haven't been exposed to many times. But 3 or 4 surgeries mentored carefully, allowing them to operate, works very well. And there are at least 3 cochlear implant programs I can list who have now become independent and they're doing well. So I have been doing that practice, supported mainly by Cochlear, and I'm very encouraged about it. Of course, you have to choose surgeon carefully, but honestly, I don't have much choice in that matter. I hope Cochlear have chosen them well.
Very good. Keep doing. Keep it up. But our standard teaching goes, Dr. Sumesh, that the newcomers should do lots and lots of cadaveric bone dissections. 4 or 5 dissections are not adequate for someone to do a live surgery independently. After doing several temporal bone dissection along with the soft tissue experience, then one should assist cochlear implant surgeries before taking up doing it himself or herself step by step. Anyway, I would invite Dr. Neeraj Mathu's reaction on this training, and what does he think? Is it the right approach, adequate training for encouraging our youngster to start independently?
Well, first of all, I would like to make it very clear. You are not judged as a best surgeon if you know cochlear implant.
Yeah, that's
this
right.
concept should go away. That if you are a cochlear implant surgeon, then you are the best surgeon, and everyone is in the race of getting the cochlear implantation ticked on his CV. It is one of the things that out of hundreds of things that a surgeon has to do, ENT surgeon has to do, one is the cochlear implant. It is good enough that an ENT surgeon is there who has got the theoretical knowledge of cochlear implantation. Good enough. And he doesn't do even single implant throughout his life. Good enough. So somehow this has come into the psyche that everyone has to do, everyone in the department, each department, everyone has to be cochlear implant surgeon also is something wrong. And that is diluting the whole care and focusing on, getting it ticked rather than doing and, taking it as a career. Because everyone cannot be. And the volume is not that much, unfortunately. And even if it is there, then everyone need not be. Some can just excel into the endoscopic work, sinus surgery work. Some can just excel into skull-based work. So that is one thing that I want to make it clear. About the training, as you very rightly said, do as many as possible cadaveric dissections and implants also with a dummy. One course, although there are so many courses, and Dr. Pasi also used to run course, and so many courses are there in Delhi and even in India, all the places. Some of the courses are very good abroad, and some of the courses give you n number of temporal bones. You can. There is one course which runs in Paris, and I have attended that. And there is a basket full of, I do not know from where he brings in the temporal bones, but there is a basket full of temporal bones which you get, and the whole course is run in a tent outside the main building. So attend some courses where you can dissect at least 7, 8, or 10 temporal bones in 2 or 3 days' time, and back to back, and that will give you enough confidence. But yes, very rightly, Dr. Someshwar said one thing. There is no point doing a course and then not doing a surgery for a decade. it usually happens, unfortunately, that you attend the course, but you do not get the chance to do the surgeries, either because cochlear implant is something not like a grommet that you can buy from your pocket and put it onto the patient. It is a costly thing. So if the patient, if the finance, if there is no finances, then you will not be able to do. So your training should be very, very aligned to your taking up as a career, and there should not be any gap. That was very rightly pointed out by Dr. Someshwar sir. Thank you very much. That's
Thank
what
you.
I.
Thank you. So very quickly, I will go to the next segment of our discussion. I will invite Dr. Namita Narayan to, keeping a time limit in mind, say something about AVT and habilitation, post-cochlear implantation.
The AVT and habilitation program in children should begin before the surgery. I would like to emphasize on that point because
well taken.
The therapists get an opportunity. The therapists get an opportunity to interact with the family because it is them, the therapist, who has to work with this family after surgery for many years. So it is very, very important and pivotal that the therapists interact and audiologists interact with the family before the surgery and they know each other. Familiarity should be there. And another thing in terms of selection of candidacy, working before implantation really helps. Lots of little things about the family, about the results, about the child is discovered, especially when we are in the era of implanting very young babies and smaller children. So lots of things are not discovered. Their cognitive abilities, there are lots of behavioral reflexes and all are not discovered if the child is not enrolled in a therapy program before implantation. So all these things, even the family will be aware, the surgeon will be aware about what we are going to face ahead. So that is one thing. And habilitation is very important, key to the outcome. Just based on good candidacy selection and good surgery, the results may or may not come. And in habilitation program, the most important person is the parent. It's not always the therapist as we think. The child may be coming to the best therapist, but if the parents are not involved, the family is not involved and focus in the program, the result may not come because the child interacts with the therapist only 2 or 3 hours in a week, whereas the child stays with the parents and the family for 24/7 the whole week. Language provider are parents, not the therapist. So that is another point I want to stress, that the family involvement is very important. Again, we live in a joint family system where we have lots of families involved. So there has to be one responsible person in the family to take the lead role, to interact, coordinate with the therapist and take the program further. And these are the three things I would like to, and then we can ensure good outcomes.
Good, Dr. Namita. I have now left with a few minutes more. I have some case scenarios to be discussed with all of you. To begin with, this 5 years old child with cochlear implantation done through the posterior tympanotomy approach, and he develops the facial nerve paresis immediately post-operatively. Dr. Amit Kishore has already given us how to avoid all these complications intraoperatively. But once the complication happens, there is a frank facial nerve paresis, grade 3 to 4, which is observed not immediately after surgery. The next morning, it is seen as it has progressed to the grade 4 paresis. So how do we manage such situation now? Dr. Rakesh, I will start with you. Dr. Rakesh. Can you hear me, Dr. Rakesh?
Yeah, I can, sir.
Yeah.
Sir, yeah, I can. The first thing is at the time of surgery, what the surgeon has identified the nerve. That is the most important thing. If he says yes, so then one can wait.
This was a case where the surgeon opened up the nerve sheath along the fallopian canal, vertical part, while digging to make the entry into the middle ear through facial recess, and did not do anything beyond that. Surgeon entered the middle ear but could not identify the stapedius tendon or even the IS joint, but could visualize the round window niche very clearly. Without injuring, without touching the drill, he made a cochleostomy and inserted the electrode array and put a lot of muscle tissue between the array and the exposed nerve, thinking that the patient will have paresis postoperatively for some time, but this has progressed on to grade 4 paralysis.
I think in this case, I would like to wait.
Wait. Okay.
And maybe on third day onward, one can go get the nerve
conduction
excitability test. Yes.
Yeah. Yeah.
And if
so it is the nerve, it is not recording anything.
I think need to be explored then. But then there is no point.
So now that is where I wanted to come.
Yes.
Now, once you want to explore, what difficulties are you anticipating in view of the presence of a redundant electrode array in the middle ear cavity and the electrode array itself in the middle ear cavity?
Yeah, the problems are multiple, because re-exploring with the implant in and then drilling with implant there, it will be a problem because the chances of damage to the electrode is high. So one is that the surgeon has to be very experienced, who has some experience in exploration with the implant in. If the experience is not much, I would like to take the active electrode out and then explore the facial nerve from the second genu down, the vertical part, upper half at least, and see if the continuity is maintained. If it's maintained, then you can cover it and then put the electrode back.
So Rakesh, you are trying to explore on 4th day only after nerve excitability test says that the conduction is not happening.
If it is no response, then yes.
Any difference of opinion, Dr. Amit?
I think here from the sounds of it, of course, you discussed that the surgeon should discuss it with a senior colleague, and I think the sounds of it, of course, the fallopian canal nerve sheath was exposed. There was pressure. It could be the pressure of the instrument or maybe the shank of the drill.
Dr. Rakesh wanted to explore on day 4.
No, I would. So I would wait because like you said, that there was a facial weakness which developed by the next day, which progressed. So I'm thinking of facial edema, facial nerve edema. So I would wait. I would repeat the nerve conduction a couple of weeks down the line, and look for any clinical improvement. I may do maybe I'm not sure if I would do a CT scan or not, because just to look at the nerve, the electrode position, that may not help.
The surgeon knows, he acknowledges that the nerve was exposed.
So if the nerve is exposed, I'm looking at edema.
But there was no, I mean, injury to the fibers.
Yeah. So I would wait.
It was only the nerve sheath was exposed.
I would wait, and it's probably compression or could be heat trauma as well.
So how long will you wait? And when would you like to repeat the nerve conduction test?
I would repeat the nerve conduction at about 3 weeks.
Okay. So depending upon the report, you will decide about exploration. Okay.
That's right.
Can I
yes.
Can I come in?
Yeah.
If we are sure that obviously there is no transaction and no damage to nerve, one can wait for 1 month, 2 months, 3 months, because the post-traumatic, the nerve get improved even after 3 months. So if the fibers are intact, then one should not be in a hurry to explore.
No, can the surgeon damage the nerve even at the level of second genu while thinning the posterior canal wall rim?
If he has not identified the stapi, if he has not identified the stapedius tendon,
yes, because of the mucosal hypertrophy, it was not identified. Yes, that's
no.
true.
But thing is, if you have that mucosal hypertrophy, that might be because of blue ear or because of the acute the otitis media and preceding 2 or 3 weeks, then it is always better to then decongest and see. Without identification, no need to go further, because that should be the message to the surgeon who want to operate. Don't proceed unless you identify the landmarks.
No, but round window niche was so clearly visible, and there was no problem in making the cochleostomy or even entering the round window niche, round window membrane, I mean.
But I think standard teaching is identify, don't depend only on the one landmark. Identify the multiple, so that you are 100% sure that you are not going here and there and damaging something which you are not supposed to do.
Dr. Shalab, I will like to have your comment on this. Dr. Shalab?
Yeah, it would be obviously an injury at the same area where the nerve was exposed in the vertical part, and probably pressure from the drill, the diamond burr, would be the cause of the injury. It could be now heat related or a direct physical injury, and canal wall edema, as Amit said, is probably the likely reason to be the cause of paralysis, in which case I think would tend to always wait, since I know the nerve is intact. But giving steroids, especially the patient still in the hospital the next day, then intravenous steroids for a couple of days should definitely help in easing out edema and decreasing the chances of having longer term complications, and I think also improve the chances of recovery quicker, so that everyone can I think breathe a sigh of relief.
Dr. Someshwar, what problems do you anticipate if you have to re-explore after a month or so?
So I was going to say exactly that if we need to re-explore, if it is going to come to that, then we have to bear in mind that re-exploration procedure is simplest if you do it the next day, because nothing is really stuck on. It is easier to if it's not a perimodular electrode or something that can be reloaded. It is very easy the next day to remove it and then re-explore it. You can put some gel foam soaked in steroids directly on the nerve. You can confirm and document that the nerve is intact. So honestly, I would be very keen to re-explore the next day itself, unless the surgeon is dead sure and he's got it on video. It is a litigious world, and if he's dead sure that the facial nerve is intact, it has not been damaged inadvertently, then I will not perform surgery, and then we should never need to re-perform surgery, because if the nerve is intact, then revision surgery will not achieve anything more. What else can you do? But if the surgeon has any doubt, then I would say re-exploring the next day is the simplest way to revise. Even 2 weeks later, everything is so stuck on that exploring this becomes quite a challenge, and what you can do becomes much more difficult. Whereas if you go in the next day, you have the option of potentially removing the implant, exploring the place, making sure what exactly is the finding. You can put gel foam soaking steroid directly on it, giving the patient the happiness that you have checked the nerve is intact, taking a picture of it, and then putting the electrode implant back, knowing everything. You could even get a friend to assist you next day, and then you will sleep much better. But this suspense, I think what Dr. Amit Kishore is alluding to is, if the surgeon is sure that it's intact, and then of course, what is the point? Then you would never expect to explore, because if the nerve is intact, what will you go in and do, especially much later? But exploration should be considered then, or if you have enough to not explore, then don't explore. But I have open cases 2 months, 3 months. It looks like, when you do that, everything is so stuck on that, I keep wondering, why do people put ties in things? This thing is not going to move anywhere unless there is infection. So revision immediately, or don't, or unless you have good reasons to wait.
I will invite Dr. Neeraj Mathur's comments on this possibility of immediate re-exploration. Dr. Somendra Singh is of the view.
I fully agree with Dr. Someshwar that either you are not sure, or you are sure. If you are not sure, then you will not be sure on the table itself. And then you must invite your senior colleague immediately at that time only, because that is the right time to do.
The patient has been extubated now.
Patient has been extubated, and now if the surgeon is very sure that he has not damaged, he had just exposed and he has not damaged the facial nerve, or if he has damaged that it was only the superficial fibers which had gone, I would say don't do anything, because in the re-exploration, you will not achieve much. What will you do? So in case, but if it was a transaction, and which is very unlikely to happen in a cochlear implant. In a cochlear implant, what usually happens is just some pressure with the burr or some injury, indirect injury to with the burr that happens. So it is not possible that this cochlear implant surgeon would ever transact the facial nerve. It will not happen because it is all under vision. He knows that he is at the facial. Usually it happens when you do not know. So I don't think it will ever happen like that. And the chances of re-explorations are very, very limited.
I totally agree with Dr. Mathur saying that it is almost impossible for a cochlear implant surgeon, for an otologist to completely transect or even partially transect the nerve while doing cochlear implantation, while drilling. It is very, very right thing. I think we should all agree to this, understand this, that we should not be in a hurry to re-explore immediately. But as Dr. Someshwar Singh insists that if you're not sure, the surgeon says there might be some injury, then you re-explore it as early as possible. I think I'm clear about it now. I'll go to the next scenario. This is something unusual. Dr. Amit, do you have some comment to offer on this? Bilateral implantee has a machine failure on one side, and the other side, which is working, the patient is uncomfortable while the machine is on.
Okay. Interesting. In this case, each of these will have to be looked at very carefully, and I would have to get our audiologist on board here, because when you've talked about failure, of course, I presume you mean that there is a device failure, on one side. So this has to be investigated both audiologically, electrophysiologically, and from a surgical point of view. So we would look at the imaging first of all, of course, history of trauma and things like that, and try and understand why there is a failure on one side. So that's one issue in itself that has to be looked at, and whether it's a gradual
machine failure has been certified by the company that this is a case of device failure.
Okay, so of course, if that side has failed, then it's pretty obvious that that device will have to be replaced unless there is any other reason not to do that. If
the other side is also not right.
Yeah. So that's once that's the side which has failed. Now, when you say we are seeing the pain and current on the other side, so of course we'll have to get our audiologist on board. Nivitaji is there, I think. So this will have to be understood as to why this is happening. We look for some simple things like middle ear infection. That can affect the psychoacoustics. Sometimes if you have an otitis media, for example. So those are the simple things. But if they have pain current, then there could be an impending device issue on the other side as well. So that's something that we have to look at. Are we looking at an early device issue, so-called a soft failure or a progressive failure on the other side too? So the company has to be involved in this. Is it an issue with the batch of devices? We know that has happened at times. So this is a difficult one for the family. But this is the way I would approach it: is with the company, the audiologist, and we look.
Dr. Navita has some comment to offer. Dr. Navita.
Yes, so the pain or the current feeling or the pain can be because of various reasons on the other side. One side is established, I believe, is a device failure. So the child is anyway going for explantation on that side, and the other side, it is very imperative to understand, are we leading to a device failure or second device failure, or it is because of any other issues. And there is a set protocol wherein we rule out each and every step to find out what the problem is, where the problem is. And that includes postoperative CT and X-ray scan also to see if the electrode array is migrated. We look at the electrophysiological test in terms of ECAP measurements or ABR measurements, and also looking at the map and the child or adult. If he's a child, it becomes even more challenging because the child is not able to describe the kind of sensation he or she is facing. If it is an adult, it is much easier to understand. We look at the impedance of the electrode array, whereas if there's any fluctuation, we look at the history. Depending, there's no mention of the time duration of this, but if it is a long standing or it is after long duration of post-implantation, then we look at the history and we look at how, what is the pattern of the data that we find post-operative and during a mapping session. And if there is a fluctuation or there's any atypical growth or abnormality that we look at the data, especially the impedance measurement and ECAP measurements, then definitely we are looking at the device failure, and that can be a marker to for further so that at one go
there is a
device
high chance of the other side, which is the child is uncomfortable with, of failure are also quite high.
Absolutely. Yeah.
Yes,
So
there looks
quickly,
like.
I'll go to just one more scenario of a very common possible condition of bilateral squamosal disease in a child who is due for cochlear implantation. Dr. Rakesh.
So, obviously, first things to manage is squamous disease need to be done. Issue is he's a child, and how old? Okay,
5 years.
So 5-year bilateral. So we have to look into the nose and sinuses, because even if you reconstruct, the chances of recurrence can be an this issue. If nose and sinuses are okay, one can attempt the removal of disease and reconstruct the attic, and then after 3 to 6 months one should wait, and then one can do the cochlear implant. Also, we need to look at the cochlea for the features which might be the basal turn. There might be problem because of recurrent this thing infections.
Will you not go for a canal wall up procedure in this situation?
No, canal wall up only. Canal wall up only.
Okay.
Provided that the nose and the sinuses are okay. If suppose there is cleft
and
palate
also
and all,
you will look at the adenoids also.
Yeah, cleft palate and all, then there is no point in keeping it canal wall up. Then canal wall down, maybe obliterate the cavity and do the implant.
Dr. Shalabh, your approach for such kind of situation?
Yeah, a 5-year-old child, most probably maybe adenoids, so an adenoidectomy, and sort of a bit of an inside-out atticotomy. Both of these seem to be just attic diseases, hopefully. And if you can exteriorize the disease, take it out, then reconstruct with cartilage, leave it alone for about 6 months, 3 to 6 months actually. The longer you wait, actually 5-year-old child, if you wait too long, then anyway the child's going to probably be
yes, that is also an issue. Yeah.
So probably wait for maybe 2 or 3 months and then reopen. Don't find any disease inside, everything looks clean, then go ahead and put an implant.
Dr. Amit, how long would you like to wait after eradicating the middle ear disease for cochlear implantation?
The catch-22 situation here, sir, is that while we know that disease may not recur very soon, but then we are losing valuable time as far as auditory brain plasticity is concerned, and that's a difficulty. So I think 3 to 6 months. So it also depends on the type of disease. If I'm looking at mucosal disease, then the risk is much less. So we could reconstruct the tympanic membrane early, or even not so much here, but certainly in the UK, where operating time was at a premium, we would do it in the same sitting. So if it's simple mucosal disease with just a bog standard small perforation, we would reconstruct the tympanic membrane and put the cochlear implant at the same time. I think in our scenario, we've got to be a little more careful. We have much more chronic disease, so the situation in India is different. If you're looking at squamous disease, then it's a different scenario. Then I would be more aggressive, and I would tend to probably eradicate all the disease, do a radical mastectomy, a blind sac closure, and then go back in after between 3 and 6 months to leave a bit of salastic, create all the space, and then go in and put the implant in. There. The trouble is
Dr. Neeraj Mathur, being a pediatric otologist, must have come across many such cases. Your approach for this kind of situation?
I would do the same thing. I will. I know the time is running out, and he has to be first. His middle ear has to be stabilized somehow, and I would do the surgery as fast as possible for the cholestoma and for the pockets which we see. Stabilize the middle ear as fast as I can, and then operate for the implant.
Dr. Rakesh, what should be the time gap between your surgery for middle ear disease and cochlear implantation?
So you're muted.
Hello.
Sir, you are muted. Dr. Rakesh, please unmute yourself.
For the adult patient, one can wait longer, maybe 1 year, 1.5 years. But for pediatrics, obviously the one cannot wait longer. So 3 to 6 months is enough.
Okay. Any difference of opinion, Dr. Someshwar?
So I just want to add that in this case, if there is no frank cholesteatoma, if it's just a simple perforation, like at least one of the images is suggesting,
you can see the pictures. Cholesteatoma is there in both the ears.
So, I mean, if the cholesteatoma is confined to the attic area, and if it is not gone into the mastoid area,
it's a limited one.
Then I think we have the option of removing the cholesteatoma with a combined approach lymphnoplasty approach, and because we don't need the eardrum to, because the child is profoundly deaf, we could use a nice thick cartilage graft to to replace the eardrum, because even if there is eustachian tube dysfunction, the chances of a cartilage graft forming a retraction pocket is very low, and then implant very soon, either in the same sitting or maybe a month later once everything is healed up. But on the first sitting itself, the cortical mastoidectomy and posterior tympanotomy itself will treat part of the middle ear issue, because you would have reduced the surface area of mucosa. So cortical mastoidectomy, posterior tympanotomy, nice repair with tragal graft, tragal cartilage, close it, either implant in that sitting or come back a month later and implant.
I will like to finish the discussion with Ravi's comments. Dr. Someshwar has kept the possibility of simultaneous eradication of the disease and cochlear implant.
Sir, the problem is that there can be recurrence of disease, or if you are not very aggressive in the first sitting, you might leave cholestoma, and that can create problem. So what I would suggest is to do a good mastoidectomy and ensure that you have cleared all the disease from the middle ear cleft. That is very, very important. Unless we are sure about the disease clearance, we should not hesitate even lowering the canal wall and removing the disease. So disease clearance is of paramount importance, and then only after 3 to 6 months we can be very sure that yes, the disease has been cleared and the patient can be now taken up for cochlear implant. And I would agree with Dr. Amit Kishore that even if you have extensive disease, you can do a cul-de-sac closure of the canal wall and then remove all the diseased middle ear mucosa, and then come again for cochlear implant after 3 to 6 months.
Thank you, Ravi. I wish I could have continued with more cases, but I think we have already exceeded the time limit. I want to thank everyone. Dr. Jyoti, I have not heard for quite some time.
Sir, Dr. Jyoti was she just left.
Okay.
All of us.
Dr. Ravi, I don't know whether you will allow our listeners to ask their queries from our learned
Sir,
panelists.
yes, we can allow, sir.
We can allow few questions, sir.
Questions from the audience.
Okay. So
if there are any.
Yes, audience are welcome.
Ravi, you had a question?
Sir, that was answered by Dr. Amit Kishore during the panel discussion about. I had question about the suprameatal approach, which Dr. Amit. So how it is different from the Virya technique. So that I think sir has already answered that it was basically for the very much anterior placed sigmoid sinus, and
that was sir, he has removed the incus on went through the editors.
Right, sir. So that is a I mean a rare thing. I mean it is to be done in very, very few rare situations where you have anterior placed sigmoid sinus, as sir has told.
Yeah, in this case, Ravi, as you've seen, I mean, if the sigmoid, if you have some space, we can always compress the sigmoid sinus, posteriorly as you do for, glomus or whatever else, and you can create space. But in this case, it was abutting the posterior canal wall, or you can have an extremely contracted, or sometimes I've had to do this a cochlear implant in a kid with meatal atresia, for example, so meatal atresia with profound loss. So as I said, these only been maybe 4 or 5 in over 1,500. Very rare situations. These have been described. The suprametal varia is one type. There are other types of suprametal. There's a middle fossa, etc. These are very rare situations. Just to show that sometimes you have to change tack, but it's not something that I personally would do as a routine. I would still persist with the posterior tympanotomy wherever possible.
Dr.
I had one question. I had one question for Dr. Amit. Can I?
Yeah, sure.
Yes. Dr. Amit, you were mentioning that you would choose a different implant for, you have different choice of implant for round window insertion and cochleostomy. What are those?
So basically, the thing is that, or I would choose the approach based on the implant that the patient is opting for. I think that's the way it will work, because we give all the options to the patients, and then depending on the budget and the choice they have. So if we are going for if we were going for a chunkier, a larger perimodular device, let's say the Contour advanced electrode that we had. Now that is not really a good implant to put through a round window, because it's quite broad, and is going to certainly fracture the osteospiral lamina. It's not designed to go through a round window. So you have to extend the round window. So that was either a cochleostomy or an extended round window. You could have the older 1J type of implant, which again was designed. Sometimes you can do through a round window, otherwise it's designed for a slightly larger cochleostomy. But if you had a straight array, most of the straight arrays, especially the slimmer ones, and now the slimmer, like the 632 or the 532, or the mid-scalar device from Bionic, so they are all amenable for round window insertion. So the choice of, my preferred choice would be to go through the round window, number one. Second is an extended round window. And last of all would be a separate cochleostomy. That would be my preference, and that would be determined by the implant that the patient has chosen to go for, or in a very, very difficult surgical situation where, like we have discussed, a posteriorly placed cochlea, a very small child, a 7-month-old baby, for example, I'm not getting a full view of the round window. If you don't, my point is, if you don't get a real clear 360-degree view of the round window, you've got to be a little careful, because only then, if you do that, can you get good angle of insertion. Because it's not just about the round window exposure. There's a classification of how the round window is angled, and whether you're seeing it from the side or you're seeing a face. If you're seeing it directly from the side, it's not very good, because if you put the implant in through there, you're certainly going to hit the osteospiral lamina. So unless you can get good view by extending your posterior tympanotomy inferiorly, so that you can direct your implant carefully. So choice of implant, number one, or the access and exposure. If I'm unhappy, for example, now with the Nucleus 532 or 632, the slim perimodular, round window is a very good option. But please keep in mind that if you do not have good angle of insertion, then the sheath is going to hit the osteospiral lamina, and you are either going to get a trauma, or you will get a tip fold over, or things like that. So in that case, it's always safer to extend the round window a little inferiorly to get good angle insertion for that sheath to go in. So that's how, in my mind, that's how I sort of prioritize and go for it. But of course, now more and more companies are moving to slimmer, less traumatic devices, which are more amenable for a round window insertion, because most people agree. There is a small school of senior surgeons who still feel a cochleostomy is better, because you get direct access as long as you use a soft approach. But with the newer implants, you can get most of them through the round window or extended round. I hope that answers the question.
Yes.
Sir,
thank you. And any more queries?
Sir, there is one question in the chat box by Dr. Avinav Gupta. He is asking whether you can give intratympanic steroids for facial nerve palsy, which occurred during cochlear implant surgery. In the panel discussion which we discussed,
where does he want to put the injection?
Intratympanic steroids for facial nerve palsy, which occurred during cochlear implant surgery.
Novel idea. Who will answer this? Dr. Someshwar?
So, I mean, yeah, I mean, like sounds good. I just started wondering whether I had thought about it or not. But I think what happens is that we are very, very keen to get it right. And intratympanic steroids as a procedure sounds quite nice. You put the patient under a microscope, but I don't feel very happy about it, because you inject it under the eardrum and then maybe it all just goes down the eustachian tube and disappears. So I somehow feel like I don't know how much
you are anyway giving intravenously.
Yeah, so I feel intravenous oral is probably more effective. And I use transtympanic only when I'm completely in a corner and I have to do something more, and then I inject. But I just don't think it's not as great, maybe, as it sounds like.
Anybody else would like to comment on this? Intratympanic steroid or facial nerve injury?
I think it's pleasing the surgeon rather than helping the patient.
Any more queries, please? Even amongst the panelists.
Dr. Amit, I have got a question for you, sir.
Yes, sir.
When do you resort to retrofacial tympanotomy for insertion of the array?
Good point. I know it's been discussed. I've never had to, I've never had to do that, I think, in my experience so far. Unless, I guess it's in theory, if the facial nerve is very lateral and you have a very, very tight facial recess and you see that on the CT scan, then you could exenterate the retrofacial hair cells and go through that approach.
What would be the indication, Ishwar? Are you removing a tumor from the fallopian canal?
No, sir,
or
not tumor. I am talking. I saw one video in which this round window was not visible, so they resorted from below, behind the facial nerve, rather than our standard technique.
Yeah, I can see. Yeah, so I think probably they would have thought that you can't see it from above the facial because it's a very posteriorly placed round window. Well, all I can say is that I have never, had to resort to that.
Anybody else would like to comment on this?
I think my point is that the position of the round window niche, which is what we see when we do a good posterior tympanotomy, can be very variable. The round window niche can be very posteriorly placed. It can be very favorably placed. And the length of the distance from the round window membrane to the round window niche can also be very variable. It can be very long, in which case you sometimes, as you're drilling, you lose it. But the location of the round window membrane itself, relative to the stapedius or the oval window, is very constant. And therefore, I feel that if, in a very comfortable approach, if the round window niche is not where I expect it to be, relative to the stapedius and other anatomical structures, then I go ahead and do a cochleostomy and complete the procedure. I think chasing the round window niche, which is very posteriorly located, carries more risk than to gain, because why would we chase it down posteriorly? People have had situations where someone chased the round window niche posteriorly so far that ultimately when they implanted, the electrode went into the vestibule. And I have certainly been, seen a case like this when I went back and helped in correcting it. So I feel that, we should just do everything has to be very comfortable. You see the place where you expect the round window niche or the round window membrane. You must always visualize the stapedius and the incudostapedial joint. And then if you can't see a round window niche, then go ahead and do a cochleostomy and comfortably complete the procedure. Do not stress yourself with chasing a very posteriorly located round window niche.
No, I would agree with what Someshwar has to say. Like I just said to Professor Mathur, the situation, we have the order of round window, extended round window cochleostomy. And if I'm in a situation that I really cannot get good access, then just go the old style cochleostomy and make sure that it's inferior. Your stapes head gives you an indicator. I remember when I was training, we were told you can't. At that time, it wasn't so sort of thought of. And I was told that if you're not sure of where the round window is or round window niche or membrane is, look at the stapes head, go 2 stapes heads down and make the opening there. And that's probably where you'll make a cochleostomy. So a bit of refinement on that, of course. But yes, I would agree with going retrofacial and complicating life doesn't make sense.
So I think I'd like to wind up with this. It's going to be 9:50 already. So once again, I thank you very much. There are few very good messages which have been gathered from the ideas of our the panelists. One is that Dr. Mathur's idea, I like that everyone is not is just hunting for doing a cochlear implant, which should not be the approach. We have to choose our wing out of the 3 wings of the ENT, 1 wing, and keep doing in that direction. Everybody is not supposed to do a cochlear implant. That's very true. This is a good message. The other message, Dr. Amit said that you start using facial nerve monitor more often in cochlear implant surgery also. You should keep it, and because the medical legal issues come up and you get caught. Then we already, Dr. Ravi remembers, we came out of one similar situation. Successfully we came out, but we were entangled. Other messages are that you should try to do as much cadaver dissections as possible, and the training programs, whatever are available, because the real cadavers are not available these days. Dr. Sumeshwar has already found out an alternate method of training that should be encouraged. Few things I wanted to say, but somehow because of the paucity of time, we could not discuss. The middle ear effusion situation we come across quite often. On CT scan also we see, and once we open the mastoid antrum and we suck that glue. I don't think it bothers any one of us. Does it bother us, Ravi?
No, sir. No.
Doesn't bother at all.
So just give a good wash, saline wash.
So with these words, I would like to thank once again the organizers, Dr. Ishwar Singh, Dr. Ravi, and all their team for giving me this opportunity for a wonderful evening spent with all of you. Special thanks to our all senior colleagues, Dr. Mathur. I have seen him doing video conferencing when I was also in an administrative position. He is signing the files in between. He is talking to people in between by going offline. But now we both are very much available for all academic activities of our field as and when you want us. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you so much for conducting such a wonderful panel. And I must thank Dr. Amit Kishore for his wonderful lecture. Anything, Ravi, you want to say?
Thank you, sir. I think we can just wind off. It's already 9:15, and I just want to say that we will continue with the academic activities of Delhi UI. Since the physical activities are not possible, we will continue on the webinar platform, and the recording of this webinar will be available on YouTube, and I will share the link with everyone. Thank you very much, and good night, sir.
Good night.
Thank you.
Good night. Thank you, everybody.
Good night.
Sir.
Thank you.
Good night, sir. Thank you.
Good night, everyone. Yeah.
Okay.